Good afternoon, everyone, and welcome back, or welcome if you're attending for our second day of the 14th Annual Sentinel Initiative Public Workshop. We're really happy to have you all here. My name is Rachel Hendrick-Stirrup. I'm the Research Director of Real-World Evidence at the Duke-Margolis Center for Health Policy at Duke University. Duke-Margolis is convening this workshop under a cooperative agreement with the US FDA. The conversation today, while it is supported through this cooperative agreement with FDA, is not a federal advisory committee. We will not be voting, making any recommendations, and so forth. During this workshop, leaders from the Sentinel Initiative, along with key collaborating partners, are sharing with us key developments from their work over the past year. On the next slide, I'll start by reviewing the content we covered yesterday before introducing today's sessions. So here's our summary of day one. We began the workshop with a keynote presentation from Dr. Patrizia Cavazzoni, who highlighted the different ways in which the Sentinel Initiative has impacted regulatory decision-making. We then heard from Cedar and C. Burr, Sentinel Initiative leadership, during our fireside chat, where they touched on some key themes that came up throughout the day, reflecting on data enhancements to the common data models, new analytical tools and capabilities, as well as strategic directions for the continued use of this valuable data infrastructure. So lots that we unpacked there yesterday. And we also heard about recent PDUFA commitments that have been achieved to improve the Sentinel Initiative, and also new challenges ahead that we should contemplate to tackle under the recently passed PDUFA 7 commitments. Then we learned about recent studies conducted by the Best Operations and Coordinating Center and the Sentinel Operations Center, and heard important updates from over the past year, as well as ongoing work to implement key capabilities like signal detection. So moving forward to our next slide, we'll talk about our agenda for today. Again, we're glad you are all here. Our first couple of sessions for the day will focus on Sentinel and best methodological advancements and innovations that are supporting the continued development and use of real-world evidence for safety surveillance. Our last session for today will highlight key collaborations within the Sentinel Initiative and work that's being done to form new partnerships with new stakeholders and existing stakeholders like the Centers for Disease Control and Prevention. And we'll also hear about the BEST system, which is forming external partnerships to leverage new data sources and capabilities through the eHealth Exchange. So on our next slide, I'll review our statement of independence, just a few housekeeping things before we get started. The Duke-Margolis Center for Health Policy, as I mentioned, is part of Duke University, and as such, we honor our tradition of academic independence on behalf of our faculty and scholars. Neither Duke nor the Margolis Center take partisan positions, but individual members are free to speak their minds, as well as express their opinions on important key issues. Now we have just one more slide with some virtual meeting reminders before we begin our first session. Attendees are encouraged to contribute to the meeting through the Zoom Q&A function. We in the FDA want to make sure that these discussions are engaging and responsive to the stakeholder community that is gathered here today. So please don't hesitate to submit any questions in this Q&A function within Zoom. We got some great questions from the audience yesterday through this Q&A feature. We hope to continue this momentum to work through some further important questions that are critical and top of mind to key stakeholders that are here with us today. So please keep them coming. We highly encourage that. And again, all of our audience members are encouraged to keep the conversation going on external venues like Twitter using the hashtag Sentinel Initiative. So hashtag Sentinel Initiative on Twitter. The hashtag is here for you all to see, just in case you want the exact spelling of the hashtag. So thanks again for drawing attention to this, this phenomenal event that is going to tackle some really timely topics with great speakers in line. So without further ado, I will go ahead and move into our first session for today, which is session 3, focused on Sentinel system innovations in data infrastructure and analytic methods. For this session, we'll consider data and methodological advancements that are facilitating studies and supporting the robust development of real-world evidence for safety and effectiveness. The session will explore the development of computable phenotypes, including the use of structured and unstructured data to automate aspects of adverse event assessments. Panelists will also consider how these data infrastructure improvements are supporting methodological advances in signal detection. So really excited to talk about this topic. It's something that we've been thinking about a lot within the Margolis Center and with FDA and other stakeholders. So I'm happy to introduce our panelists for this session, Sentinel collaborations for the COVID-19 response, who are Sebastian Schneeweiss, who's the Chief of the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital, Rishi Desai, Assistant Professor of Medicine in the Division of Pharmacoepidemiology and Pharmacoeconomics, also at Brigham and Women's Hospital and Harvard Medical School. We have David Carell, who's Associate Investigator at Kaiser Permanente, Colin Walsh, Assistant Professor of Biomedical Informatics, Medicine and Psychiatry at Vanderbilt University. Also, Richie Weiss, Associate Epidemiologist in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital as well. Keith Marsalo, Associate Professor in Population Health Sciences at Duke University. Lastly, we're joined by Shirley Wang, Associate Epidemiologist in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. Now I am ready to pass this off to Sebastian, who will start us off.
Thank you so much, Rachel. It's a great pleasure to be here. And my name is Sebastian Schneeweiss, and thank you for the introductions, Rachel. And I'm going to start us off with the review of the Sentinel Innovation Center and what we are planning going forward. So if you forward the slide, one item, you see the agenda for today, or it's difficult to see apparently because it's black on blue, which is different how it looks here anyways. So I will very briefly speak about the division of the Sentinel Innovation Center. We have a presentation on causal inference, and that is key to many of these activities in the Innovation Center. How can more detailed data sources like EHR data combined with claims data improve our causal understanding of how medications are related to health outcomes, intended or unintended health outcomes? In order to extract information from complex data sources, we need feature engineering activities that are scalable across multiple different data sources with unstructured, semi-structured information, structured information. So quite some activities in that space. With regard to the data infrastructure, we'll update you on what we have achieved already in this space on standing up a variety of networks that have access to increasingly clinically detailed information that is necessary. And some more examples on detection analysis, how we can use these data sources to even earlier detect potential safety issues and then work them up in other capacities. Next slide, please. Next slide, please. The vision for the Innovation Center is to improve human health by expanding Sentinel's active risk identification analysis. These are these ARIA studies that are based on secondary data largely in order to expeditiously understand in a robust way the safety of medications. So improve those capabilities to subjectively use electronic health care data sources, and that is largely electronic health records combined with claims data, for drug safety surveillance and increased confidence and use of real-world data for regulatory decision-making. Regulatory decision-making, again, here a focus on causal relationship between drug use and health outcomes. Of course, we're not forgetting descriptive analysis that are equally important, but the Innovation Center spends quite a bit of time on inferential studies, the relationship between drugs or medical products and health outcomes. Next slide, please. The specific mission that is derived from the vision is to establish a query-ready, quality-checked, distributed data network containing electronic health records with reusable analysis tools. It's basically expanding what was built already through the Sentinel system over the past 10 years, this very large claims-based and some EHR data-based data sources that are queryable expeditiously with quality checked analysis tools. So now pulling in more electronic health record data, where we hope we can expand the range of studies, the range of questions that can be answered beyond claims data analyses that we do understand quite well at this point. Next slide, please. We're entering year 4. Up to year 4, we have invested quite a bit in understanding how electronic health records specifically can contribute to inferential analyses and the surveillance for drug safety issues. And starting year 4, we're putting the outcome of all these investigations together in this network that we are building that is easy to query, expeditiously queryable, and quality approved queryable. And so we're in the middle of that. The presentations that you hear today from our results from studies that happened from year 1 through 3 and are the inputs for the building of the data network. Next slide, please. We spoke about the speakers already. This is just a reminder about the leadership for the Sentinel Innovation Center. So we have Rishi Desai to the right of myself, we together are running the Innovation Center together with our partners from Duke University. This is Professors Curtis and Marsolo, with our partners from the Kaiser Permanente Washington, University of Washington, Professors Nelson and Hegarty. And then, of course, our partners from Vanderbilt University, Professor Johnson has just moved to the UPenn, as well as Michael Matheny. And today, one of today's speakers also Shirley Wang, who's helping us in the leadership team on the Brigham side. Next slide, please. With that, I hand over to Rishi Desai, who's setting the stage for the following presentations. Rishi?
Yeah, thank you, Sebastian, for those introductory remarks. And hi, everyone. My name is Rishi Desai. I'm an assistant professor of medicine at the Division of Pharmacoepidemiology at Brigham and Women's Hospital. And I also am the operations chief for the Sentinel Innovation Center. And it's really a big privilege for me to be able to set the stage for our speakers today, because this is the line of work, as Sebastian mentioned on the previous slide. We have 19 ongoing projects, and it's a big portfolio involving many dedicated investigators. So big shout out to them. And my job over the next 5 to 7 minutes is to just introduce the central idea behind initiating these projects and how these projects fit together to meet the overall goal of the Innovation Center. So next slide, please. Next. Yeah, you can click this through. Thank you. So I just wanted to give you a backdrop of why the Innovation Center exists in the first place. So this really goes back to 2017, 2018, where we had about 10 years of experience with the Sentinel, Mini Sentinel, and Sentinel initiative. And we appreciated the value that insurance claims data brought, which was size and the ability to longitudinally track people. However, we also were realizing quickly that the limitations of the insurance claims data became quite important in some cases, where we were just not able to get granular clinical information just through billing records, which were limiting our ability to do some studies, maybe because we are not able to identify outcomes of interest or indications of interest and things like that. So this is a couple of, I think, publications that set the stage for Innovation Centers. On the left, what you see is a paper by Jeff Brown and colleagues from the Operations Center leadership, which identified this need in this paper. And on the right, you have a really comprehensive vision post from former Commissioner Gottlieb, where he recognized the need to rely on various streams of data to get a more complete picture of the patient, and not just focus on insurance claims data. So a cross-cutting enterprise for real-world evidence was really introduced in these early publications that set the stage for us. So next slide, please. and click this through. Thank you. So what we really knew at the 2020, around the time of 2020, was that a Sentinel system was doing great things based on insurance claims, but there were some critical limitations. And we wanted to kind of address some of that to get to our final vision, which Sebastian just mentioned, as standing up this EHR claims link-based asset for 10 million or more lives that is very ready and quality checked. And so what we spent our first year doing was really thinking a lot about what it takes from from having this need to getting this vision. This is what you see in the central 4 squares, where we identified 4 key areas where we wanted to focus on. So this included data infrastructure, which is of course something that you need to build up the infrastructure, feature engineering approaches, so data science innovations like NLP, machine learning approaches to information, to extract more information more rapidly or in a timely manner. We also are not forgetting causal inference, which is at the center of what we do, because we do want to know about the effect of a medication, a safety outcome in most cases, but we want to make causal inference. So that's at the center. And finally, detection analytics is the first step, the precursor to all the causal inference activity, where we want to identify signals that arise in these healthcare data sources. So we identify these 4 key strategic priority areas and initiated projects in these 4 streams to be able to deliver on our promise of the 10 million plus lives to the FDA. Next slide, please. And so this is again a slide showing our thought process around how to think about the needs of the program, keeping the key use case, the FDA use case in mind, which is the causal inference of safety outcomes for medications. So it is one thing to stand up the 10 million lives data infrastructure, but equally important is to anticipate and identify the needs where we want to invest some resources beforehand in anticipation, the issues that you might face when you have a system like this. So this is a process diagram outlining our thought process. So you go from the top left corner where you have a system ready, then you design your study with sound epidemiologic principles. So that's the causal study design piece. And once you have a design set up and ready to go, there are various innovative approaches that you can take to make the best use of the EHR-based asset. So in the pre-exposure space, you have confounding identification, you have identification of your indications. In the post-exposure space, you have outcome identification. And both of these are quite ripe for implementing various innovations. And the red text that you see here are the gaps that we see in these process, where we felt like there was a need to invest some resources in research. For example, you have issues on missing data, that come up day one once you start using EHR-based large healthcare databases. And so next slide, please. And so what we do is we identify these needs and we try to plug holes in our knowledge through initiating specific projects. And so it's a really a thoughtful way for us to try and identify how to address these knowledge gaps. And the presentations that you will hear today will really try and identify solutions to some of these problems. So next slide, please. Next, one more. And we also are not forgetting about the central idea of having a process in mind, which is really based on the fact that you need to think carefully about various steps, going from a study question to the inference. And so we are also actively engaged in preparing these white papers and guidance documents. So this is in a draft stage, but an example of process guidance that we are aiming to put out for the Sentinel, how we at Sentinel think about design issues and various steps along the way. So for example, fit for purpose data, how do we think of fit for purpose data? How do we define it? How do we operationalize it? So very pragmatic guidance that we are hoping to put out to hopefully also motivate similar considerations from the broader clinical research community. So just wanted to highlight that. And with that, I think this is my last slide. So can you click one more time. That's it. And so I would now hand it over to our colleague, David Carell, who will be talking about some computational, computable phenotyping activities in the Sentinel network.
Thank you, Rishi. Is my video on for y'all? Yes, I see it is. Okay, good. So it's a pleasure to meet with you today. As Rishi was just mentioning, a lot of the work that we're trying to accomplish in the Innovation Center is to identify these outcomes, covariates, and so forth of interest so that we can do this sort of automated safety surveillance and do it efficiently and in a replicable and scalable way. And so, spoiler alert, what I'm going to share today is some pretty exciting, we think, results where we have tried some really scalable NLP, natural language processing methods, and have found them to be pretty successful. Next slide, please. Brief over the agenda. The motivation, as I just mentioned, was to improve ability to identify outcomes of interest. And sometimes, as others have mentioned, these structured data that we've been using for many, many years and automated approaches are insufficient. They're not accurate enough. The other thing we want to do is reduce the overall amount of time and effort it takes to develop these algorithms. And so that's a key feature of what we're going to talk about today. And in this context, the objective here is to look at a scalable NLP-driven approach to improve overall outcome identification. And we're going to look at that in the context of an algorithm to identify patients with symptomatic COVID-19 disease. We'll look at the results and talk about future work as well. Next slide, please. Okay, and move on, please. So I mentioned ARIA, the Active Risk Identification Analysis System. It applies these analytic tools, including completely automated algorithms to identify these outcomes, to the Sentinel common data, these secondary data that Sebastian mentioned, to perform safety studies. Next slide, please. ARIA is sufficient whenever certain conditions are met. When the data are adequate for identifying the health outcome of interest, whether that's anaphylaxis or some other condition that's a side effect potentially of a medical product, identifying the exposure and comparator groups and confounders and covariates. And then also when the methods can assess the exposure-related risk with satisfactory precision. Next slide. ARIA is insufficient sometimes, however, and in the data in the past that we've seen, as many as half of the outcomes we'd like to identify with ARIA, we haven't been able to identify. And often those are health outcomes of interest, things like anaphylaxis or MI or whatever the outcome is. Next slide, please. Here's some examples of when ARIA has been sufficient for identifying outcomes. I won't read through them all, you can look at them there. And then on the right, somewhere ARIA has been, excuse me, insufficient. Acute pancreatitis is an example, some pregnancy-related outcomes. Anaphylaxis is an important one. Note that fatal MACE, major adverse cardiac event, has been insufficient, but identifying MACE itself without the fatality component, the structured data work reasonably well. Next slide. So our question becomes, can NLP extracted data help improve the accuracy of identifying these kinds of outcomes? And secondly, but importantly, can we do it in a scalable way that doesn't take lots of time and effort? Next slide, please. So in order to do this, we have to overcome these challenges of the traditional approaches to engineering these algorithms. And the two big time and cost burdens are feature engineering and gold standard creation. By feature engineering, we mean use of experts, clinicians, people with knowledge of electronic health records, NLP experts, to identify what information they're going to attempt to extract from an electronic health record and create operational versions of that. It can be very time intensive. The data may not be available in all settings. It can be expensive, or I'm sorry, the expertise may not be available in all settings. It's in any case an expensive undertaking. And there's also a potential for operator dependence. How the team I work with might engineer features could be different than, another team features that they engineer. And then it's very, as I said, time intensive. For gold standard data creation, it's the same thing. It takes lots of high cost, scarce expertise, and it's very time intensive. Next slide, please. So the take-home message here is that these time and cost burdens constrain the number of outcomes that can be investigated with a certain amount of resources. And that's a bottleneck that we want to try to overcome. Next slide, please. I won't dwell on this slide, but the take-home message here is that this manual approach to feature engineering, the thing that's very expensive, requires lots of expertise, it's time intensive, has many steps. And if we could advance the slide one more click, what this shows is that there's a lot of personnel doing lots of different things that take time and expertise. And this is what makes that traditional approach to feature engineering non-scalable. Next slide, please. Similarly, for gold standard creation, we have to define outcomes, develop a protocol, test it, iterate, finally review all the charts. It's a very time intensive process. If there's a way that we can create algorithms without gold standard data, we'd be much better off. Next slide, please. Okay, next slide, please. Thanks. Yeah, we had a little animation there. Okay, so here's our objective. One more, please. We want to answer this question: can scalable NLP methods improve outcome identification in Sentinel? And by scale, we mean methods that are affordable, timeline friendly, and can be applied in diverse Sentinel settings. And there are many Sentinel partners. They have heterogeneous data sources and varying access to technical experts. Next slide, please. Okay, and one more. So here, the method that we've applied is a method reported in the literature some time ago by you and colleagues in JAMIA called the FENOR method. It's a general purpose automated approach to creating computable algorithms. Next slide. It uses automated NLP for feature engineering instead of that very time-consuming manual approach. Next slide, please. It uses silver standard surrogate labels instead of that expensive gold labeled data. Next slide, please. And it combines machine learning methods for model training. Next slide. Here's an example of how automated approaches can be used to develop features that are used for modeling. Next slide, please. In the first step, instead of relying on experts and their review of chart notes and data, we identify knowledge-based articles, clinical knowledge-based articles on the topic of interest. In this case, it was COVID-19. You can see here, there's a Mayo Clinic article describing the condition, Medline Plus, and so forth, including Wikipedia. We treat each of those as documents, and we mine from them every medical concept that they mention in each article. There were, as you can see at the bottom, 504 unique medical concepts mentioned in at least one of these 5 articles. Next slide, please. We then apply a simple rule. Again, this is just applying the method of you and colleagues in the published piece. 158 of the 504 concepts appeared in at least 3 of those knowledge base articles. So those are the ones that we then advance to be our topics for engineering features that are going to be used in modeling. Next slide, please. And then we simply look at patient notes during some catchment period around the index date. And we count the number of times each of those 158 concepts appears in a patient's notes. We now have 158 features or potential predictor variables. They could range from 0 to some upper, potentially high number of the number of times their chart notes mentions each of these concepts. Next slide, please. So that gets us our features. Now we're talking about how to avoid the gold standard data. You and colleagues propose using silver standard surrogates. And by this, we mean just anything that's countable from the patient record and it can be counted and assembled with relatively low effort. For example, for identifying COVID-19 disease, we counted the number of days that a patient had a COVID-19 diagnosis code within a 60-day window centered on their index date. Alternatively, it could be the number of days with any of several diagnoses that are all related to COVID. Finally, we also used a count that was actually based on the number of times COVID-19 was mentioned in their chart notes. Next slide, please. An example of the distribution of one of these go on now. We're almost here. The rest of the story moves along quickly. This slide just shows you at the bottom, there were over 24,000 patients in the study at Vanderbilt University, over 8,000 at Kaiser, and we had gold standard data on them as well, on small subsets, 400 to 500. Next slide, please. And maybe we need there we go. So let's look at the results. So next slide, please. We did one model for each of the 3 surrogate labels. There were 2 study sites. You can see the AUCs there. Lots of ways to report the results, but we looked at how does the model perform in terms of sensitivity if it achieves a positive predictive value of at least 0.8. And you can see the numbers there are all very high and quite acceptable. Next slide, please. Here's another way to look at the data, looking at the PPV and sensitivity curves. You can see that the models are different at the 2 sites, but because it's an automated approach, it's very easy to implement the models at both sites. So every site can have its own model and its own performance metrics. Next slide, please. Okay, so and here we can click through about 3 times, I think. The bottom line is these models achieve strong performance with modest expertise on a reasonable timeline in heterogeneous settings. And one more click. This is basically meeting our obligation to come up with a scalable approach. Next slide, please. One more. So final next steps. We can advance the slides again. In the future, we need to now apply these methods to more acute phenotypes and see how they work, where they're strong, where they might not work so well. Even in cases where if they didn't work well, I think there's a very compelling case to start with these automated methods as a baseline. We also need to try to look at sub phenotypes, for example, not just COVID-19 disease, but high severity COVID-19 or acute pancreatitis. We also have to do things like look at how much effort should be put into the NLP mining of the data from the chart notes. Is it important to use negation or not? In the COVID space, we didn't use negation and it worked fine. And then also looking at different strategies for defining these silver labels. It turns out that it's very important to characterize a silver label in a way that's closely related to the outcome that you want to look at. That's all I have to say. I just wanted to acknowledge 2 different teams that I'm a member of. One is on the next slide, this COVID-19 project slide, co-led by Josh Smith, whose name is over there on the right under the Vanderbilt University group. And then on the next slide, another group with a wide range of excellent collaborators that's looking at these advanced phenotyping methods. And that's all we have today. Thank you.
Thank you so much, David. We'll go ahead and move forward to the next presentation by Colin Walsh.
Thank you so much. And I'm happy to be here with you today. Again, I'm coming to you from Vanderbilt University Medical Center, and I'm going to focus on the problem of probabilistic phenotyping. So the likelihood that a phenotype is present, but looking specifically at incidents, events that happen at some point in time in health records. And I'll describe that in more detail. Next slide, please. The problem that motivated a lot of our work is the idea that as new medications or new devices enter the marketplace after the first rounds of trials to make sure that they're safe, that they seem to be efficacious, and now they enter the wider world, is the idea that as you move from thousands or hundreds of thousands to millions of people potentially receiving, let's say, a new medication, there may be issues that develop. And these issues might develop across various health systems all around the country. And how do you design and think about systems that help us better watch for those incidents happening at scale? The idea that me as a primary care doc, which is my training, if a patient comes in with a new symptom, and I think that might be related to a new medication that they've received, that's an important thing for all of us to know about, certainly an important thing for a program like Sentinel to know about. So next slide, please. The idea here is that as these individuals receive these new devices or medications, how do we identify, specifically here, we're focused on adverse events, so things we'd like to avoid or things we'd like to learn more about so the next person could avoid it. And how do we do that with data that are typically messy, very noisy, which means there's a lot of data in them that simply isn't good signal to train an algorithm or to really identify our attention. And again, how do we do that at scale? Next slide, please. So happily on our team, led by a co-investigator of ours in the work group, Dr. Adi Bahan, there's work using a technique called natural language processing, which I don't think is a brand new concept for this event and for many of you. The idea that how do we take from text, from typically free text, unstructured text, signal that we care about a lot. And this is a paper by Adi from a few years ago where he used similar techniques to what you'll hear about with some really important modifications to identify problems like homelessness and patients experiencing homelessness and adverse childhood experiences, things that have a major impact on our health, but actually are not well captured in structured clinical data. For example, diagnostic codes like ICD codes, for those of you familiar with those. And I'll talk about those more. Please, next slide. One nice piece of this is that we really care not just, so there's let me frame it this way. There's the idea that if you took every medical note written about me and every data point about my healthcare history, and you showed that to an algorithm, there are some insights you might gain over my lifetime. But there are also really important times that we care about changes in our health. Or for example, I have a cough today, and that's different than worrying about every cough I've ever had. The former is much harder. The idea that we want to find that new incident of something happening in time ends up being a really hard problem, but a really important one clinically, because we change. We're constantly changing, and our health is constantly evolving. And so this graph from that first paper by Adi shows that this technique can potentially help us understand states that individuals are going through. And so this concept is going to be very important as we move into the work of our work group. And so we'll talk about that now. Please proceed. Next slide. So this is the overview for our project. And the goal here is not to talk through every component of this slide. It's to give you the forest for the trees. Now, the forest here is that we want to adapt that approach by my colleague, Professor Bahan, make it something that's a bit more time sensitive so we can find those new incidents that I mentioned. And we want to test that in not just one set of phenotypes, but multiple sets of phenotypes to understand not just is it accurate, is it feasible, but is it generalizable? That generalizability ends up being really important. We might care about 2 phenotypes in our project, but down the line, we might be caring about tens or hundreds or even more phenotypes. So does it work at scale and does it work in a generalizable way? On the left side of this plot, of this image, you see a plot basically showing work that we've already done. The approach you're about to hear about in much more detail has been applied to a set of phenotypes that my team and I care a lot about, and that's in the area of suicide prevention. And what you see there is what's called a precision and recall plot. The idea that we've taken the NLP approach that I'll be describing, applied it to suicidal ideation, suicide attempt as a set of phenotypes that we've been thinking about now for going on 7 years. And the algorithms seem to be accurate. And importantly, they seem to be accurate in a way that isn't unfair for any particular group by coded race. And when I say coded race, I mean that's that entry in electronic health record that gets put in, and those are imperfect data. I am the first to admit that, but it's our very first step to show that not just could these algorithms be accurate, but might they be fair? We really care about them being fair. That's the image in the middle is the idea that we've built on this work and thought more about the suicide risk prediction space to understand how well our risk models actually work to predict a really important outcome in suicidality, which is the most important one of all, which is preventing death from suicide. That's that middle plot. In the interest of scope and time, I won't talk much more about that today. And now what I'm going to talk a lot more about is this on the right side, which is aim 3. Our third aim is testing that approach we tested on the left side of the screen in a new phenotype on the right side of the screen. So let's do that now. Next slide, please. So we're going to move through to ask the question, if we have good precision without differences by coded race in one phenotype in the space of suicidality, what happens when we move to a new phenotype? Next slide, please. After much discussion, we focused on sleep-related behaviors as our phenotype. Why do we care about that? One, sleep is a challenging issue. It's not well recorded in structured data. When it comes up in a clinical encounter, it might be almost something that gets sort of buried in there, and it might actually end up being very important. It's also the kind of thing, as medications get introduced or as medications get taken, individuals might have sleep disruptions related to medications. We care about it there. We thought it was feasible for this text extraction approach, and we have a reasonable start. You've heard this concept of a gold and silver standard from my wonderful colleague, Dr. David Carell. And so diagnostic codes end up kind of helping us a little bit along the way. And you'll see how we use that as a silver standard in a moment. Next slide, please. So after much discussion, we initially started thinking about a class of sleep-related behaviors called parasomnias. After much discussion, one of the things we've been learning in this project is specificity of the phenotype matters a lot. The right level of granularity. Parasomnias ended up being a little bit too big of a tent. It was too heterogeneous and accounted for too many different types of behaviors. So we honed in a little bit more on sleep-related behaviors, specifically sleepwalking, sleep eating, sleep driving. So our NLP is going to be seeing these core, what we call seed phrases around sleepwalking, sleep eating, and sleep driving to inform the probabilistic language models that are going to then be applied at scale in our health record. Next slide, please. So this is the overall pipeline. I'm going to talk you through each step of the way. Next slide, please. So we start with a sleepwalking query on the top left, and we want to always think about our data source, and that's shown here on the bottom. In our case, it's the Vanderbilt electronic health record, looking at around 100 million clinical notes. So it's a nice, rich repository collected over a long period of time. But I want to be really clear here. This approach is by design intended to be agnostic to the source of text and the format of text, where you don't worry a lot about what type of note each one is, who wrote it. Those things do matter. We do care about those things, but we wanted an approach to work at scale that was agnostic to those specifics. And that's actually what's happening here. Next slide, please. We asked that first question, what phrases are we going to use to direct our algorithm? I've already told you those: sleepwalking, eating, and driving. Next slide, please. We're going to take those phrases and essentially tackle the problem of taking words, which we read readily as humans, and turn them into numbers, which is something that computers read very readily. And the idea here is taking something like a probabilistic language model and the idea of something called, for example, word2vec, which is a very well-known algorithm out there, which is the idea that if you take the word king, subtract man from it, you get the word queen, is one common example of how that concept is described. And that's called query expansion. And you see word2vec there, and this association between words matters a lot. Next slide, please. So as we retrieved the terms around this, SDH here, it's going to be defined in a subsequent slide to be clear. This comes from Adi's work in 2018, this image, which I really liked. SDH is social determinants of health. The idea here is essentially phenotype retrieval is actually probably better said for our project. We retrieve these concepts, we weight them. And you heard from my colleague, David, and the last one, for some use cases, negation isn't that important. In our case, it is. It ends up being important as well. Now, next slide, please. We really care about humans in the loop, essentially, to be able to review our results for relevance. So that ends up being really critical. Next slide, please. Based on that feedback, we go back and iterate and refine. Next slide. And then we send those results for a full manual chart validation, multiple reviewers and guidelines. Next slide, please. So this is our pipeline, and I'll talk you through it now. Next slide, please. On the left, we essentially apply our NLP to clinical notes. We looked at around 120,000 charts there. The score is the likelihood the phenotype is present. Next slide, please. We then use our silver standard, which has been defined, those ICD codes, to show we're off to a reasonable start, but now we're going to do it with a gold standard next. Next slide, please. We talked a little bit about silver standards. So in the interest of time, I'll breeze through this. We used ICD codes as our silver. We're going to use chart review as our gold. Please, next slide. And then we're going to use that preliminary performance to estimate, when we do a full chart validation, how many charts do we need to look at? That ends up being quite important because we want to be confident in our results and understand how likely it is that there's error there. Next slide, please. And now we're in the middle of our chart validation. That's around 4,279 charts, and that's underway. Next slide, please. So key steps here. We know we need guidelines for that annotation, and we can talk a lot more about that in Q&A in terms of what goes into that. We started with a training set, a small number of charts, just to make sure we've got the process down and we didn't find any edge cases right out of the gate. And then we're going to check our performance in batches. So after the first 1,000 charts. So this is a feasible, accurate, and now we're testing whether that's a generalizable approach to understanding probabilistic phenotyping of incident outcomes. And then last slide is my acknowledgements. And I thank you for your time.
So much. Great presentation. Next up, we have Richard Weiss. Richard, I'll let you take it from here.
All right. Well, thank you. Thanks for inviting me to speak today to talk a little bit about some of the work that myself and colleagues have been doing over the past year through the Sentinel Innovation Center. So as you've seen from the presentations already, and as you'll see from later presentations today, a big focus of projects that have been sponsored by Sentinel over the past few years has been looking at ways of extracting information from electronic health records to improve real-world evidence generation. And so this project that I'll be talking about today fits into that overall goal, but here we're extracting information from electronic health records in a little bit of a different way. Instead of focusing on clinical phenotyping to improve outcome assessment or prediction modeling, in this specific project, we are interested in how can we extract information from electronic health records at a very large scale to improve high-dimensional confounding control. And so in the next few minutes, I'll just give a very brief overview of the work we've done here. Next slide. And next slide. So just to give a little bit more motivation behind this project. So confounding, as Rishi mentioned early on in the introduction to these presentations today, confounding control and causal inference is really central to everything we do in these healthcare database studies. And this is not a new problem, but confounding really still remains arguably the biggest challenge to being able to extract valid evidence from these healthcare database studies. Traditional approaches to control for confounding have really relied on investigators to have to specify a limited number of investigator-specified variables. And this, of course, works well in many applications in pharmacoepidemiology, maybe most applications, but there are certain situations that are highly relevant to Sentinel where this can be very challenging. When we have new treatments, for example, that first come onto the market, there's a large literature now showing that the indication for treatment can be rapidly evolving during these early periods of a treatment's approval or post-approval. And knowing what variables to adjust for can be very difficult. Next slide. But perhaps even a bigger challenge that's more general to pharmacoepidemiology is even if we have a pretty good idea of what variables we want to adjust for, a lot of these variables are just not directly measured in these healthcare databases, either healthcare claims or electronic health records. And so this is a challenge that's really been discussed now for over a decade in several publications with different research groups. I'm really beginning with a few publications by Sebastian Schneeweiss and his colleagues back in 2007, 2008, where they argue that we really should be thinking differently about how these healthcare databases capture confounder information. Instead of thinking of them as directly measuring information on health concepts and features that we would want to account for in our studies, like frailty or health-seeking behavior, instead we should be thinking of these databases as largely containing large numbers of codes or constellations of codes that indirectly capture information on these variables that we often want to adjust for in our studies. Next slide. And so this is the idea of high-dimensional proxy confounder adjustment that's become influential, again, over the last few years in pharmacoepidemiology. And there's been a lot of groups that have done a lot of great work in this area. Martin Schumi, Patrick Ryan through the OMOP Consortium, Robert Platt up at McGill University have all published really good papers and been very influential of expanding tools to improve confounding control through the idea of large-scale or high-dimensional proxy confounding control. But a current limitation of approaches is that they really require data to be in a structured format. They don't leverage the full information content that's available in electronic health records, specifically free text notes, potentially containing very rich information that's not really utilized for this purpose. Next slide. So that was the goal of this specific project. We wanted to explore how we could use the full information content in electronic health records, specifically these unstructured free text notes, for purposes of improving large-scale proxy confounding control. And so this project was really divided up into two phases. In the first phase, we leveraged ongoing work that was being done in parallel with the Sentinel project that was being done through an R01 that was being led by Josh Lynn, where they were interested in exploring ways of applying natural language processing for the purpose of just creating structured features from unstructured free text notes. So the application of natural language processing in this context was very different from how we typically apply natural language processing to EHR data, where typically we're interested in clinical phenotyping, outcome assessment, interpreting the specific meaning of the generated features. But in this context, we aren't really interested in interpreting the meaning of the clinical or the generated features. We just want to create structured data, which can then be fed into machine learning algorithms for high-dimensional confounding control. And the second aim, or the second phase of this project, is really where the Sentinel work kicked in. Is once we have this structured data, this ultra high dimensional data structures, where we have NLP generated structured features, as well as claims codes and structured codes from the EHR as well, is how can we best use this data or identify confounded information in this data. And so that's what this project focused on, specifically how we can apply principles of targeted learning, which is a causal inference framework developed by Mark Vanderland and his team out at UC Berkeley, to improve large-scale confounding control with these types of data. Next slide. Next slide. So the data that we were using we had linked EHR claims data. We had Medicare claims that we linked to EHR data from the Mass General Brigham, which is the largest healthcare provider in Massachusetts. Next slide. From this data, we generated 2 cohort studies that give an idea of the data structure that we were dealing with. So if we just focus on study 1, where we were comparing the effect of NSAIDs versus opioids on acute kidney injury, we had about 20,000 individuals for the sample size. And if we look over at the number of baseline covariates, we had about 15,000 total baseline covariates, 91 of which were pre-specified, and the remaining proxy variables from NLP features and claims codes. We actually had many more variables available for adjustment, but we implemented an initial screening where we removed very sparse variables that were unlikely to contain any meaningful information. Next slide. So with this data, we were interested in exploring different methods for confounder selection. And we focused on lasso-based approaches for a couple of reasons. First, lasso models are the most widely used tools for high-dimensional variable selection in the biostatistics and epidemiology literature, and there's just been a lot of work to expand lasso-based tools for purposes of causal inference. And so we looked at 4 different ways of implementing lasso regression, where, again, lasso just implements a type of regularized regression to shrink imprecise model coefficients towards 0. We looked at the traditional lasso, which selects variables to optimize predictive performance, where in this case, we're fitting a propensity score model. So we're trying to optimize predictive performance for treatment. And this is actually the approach that's recommended by OMOP in their work on large-scale covariate adjustment. Model 2, we extended model 1 by looking at what's called the outcome adaptive lasso, developed by Susan Shortreed and her team at University of Washington, where instead of just focusing on predictors of treatment, you place more weight on variables that are strongly associated with the outcome and force those variables into the model. Model 3 is what's called the collaborative controlled lasso, which implements the principles of targeted learning with lasso regression. So we select variables to try to minimize a bias variance trade-off in the estimated treatment effect using the principles of targeted learning. And then model 4 It combines kind of model 2 with model 3, where we have collaborative controlled lasso with the principle with an outcome adaptive variation, where we force strong predictors of the model into the model. And then models 5 through 8 were the same as models 1 through 4, but we just implemented the models using what's called cross-fitting or sample splitting, which is widely used and recommended when implementing machine learning tools for causal inference. Next slide. So we conducted extensive simulations using both fully synthetic data as well as plasmon simulations, which is just a way to incorporate real empirical data into the simulation process to better reflect the complexity of real world data. Next slide. Next slide, please. Next slide. Yeah, next slide. So I'm skipping ahead here because I'm running out of time. So I just have a couple minutes left, so I'll just very briefly go over some of these simulation results that I think really give the overall trend and idea of what we were seeing across the range of simulations that we were running. So if we just focus on the very top left plot here, plot A, we can just look at the bias of some of the different models that we were running. So on the y-axis, we have the bias, and then on the x-axis, we have different scenarios that we were looking at. For each of these scenarios, we held constant the number of confounders that were available in the data that were simulated, which was 100 confounders. And then we increased the number of spurious variables or noise that were simulated into the data. So on the very left side, we have only 500 spurious variables. And on the very right-hand side of plot A, we have 10,000 spurious variables, where we had a very large amount of noise. And what we were interested in is seeing which of these techniques can best identify confounder information as the amount of noise increases. So not surprisingly, as we increase the noise in the data, the bias of all the methods increases. But what we consistently found is that if we apply the tools of collaborative targeted learning, especially when we combine that with outcome adaptive lasso with cross-fitting, we can actually do much better than just traditional lasso prediction for identifying confounder information in these ultra high dimensional data sets. Next slide. Next slide, we'll skip ahead a couple more. So next slide and next slide. Next slide. So yeah, so just in general, we found that, I've already said this, so maybe we can just skip to the next slide since we're running out of time. We found that the tools that tend to perform the best in these settings actually overfitted the lasso model. So it was very difficult to know which variables we should adjust for, but instead of trying to select these models to optimize predictive performance, if we actually overfit these lasso propensity score models using principles of targeted learning, as well as combining that with cross-fitting to avoid too much reduced covariate overlap, we can actually do quite well in identifying confounder information in these very large high-dimensional data structures. And so, next slide. So just like to acknowledge the team that I worked with, a lot of really great individuals from various institutions. And with that, I'll close. Thank you.
Thank you so much. Next up, we have Keith. Keith, feel free
Great,
to take
thank you. Great, thanks. If we go to the next slide. So this project is going to be a little bit different than some of the ones that you've been hearing about so far, where this is really more focused on sort of infrastructure as opposed to sort of methods or algorithm development. So it's going to have a little bit of a different flavor. But the overall motivation of what we're talking about. So we heard a lot of great work that's happening, sort of leveraging natural language processing, things derived out of unstructured text. And so the goal of this project is really to help the Sentinel network think about how do we best incorporate that information into the existing sort of common data model framework so that it's standardized and we can leverage it for sort of multiple analyses. And so the way that we broke this project, broke it up was really into 3 separate objectives. And so the first one was thinking about sort of what information is important. And so like if we were going to extract information from unstructured text, what are the things that we would like to focus on? Again, in some of the previous presentations, we heard about, sort of engineered features, sleepwalking, COVID, things like that are being kind of derived.
that's one of the more sort of advanced uses of natural language processing. There's also other sort of more mundane yet still very important uses of it, where if we're just kind of extracting keywords from text, you want to find ejection fraction or sort of tumor staging or genomic results, right? You could pull that out of the note and then use it in an analysis. And so we kind of want to be able to support sort of all those different use cases. So understanding kind of what information is important is sort of the first step. Then once we had that, we said sort of two different things. One is really, kind of how is NLP being used within the Sentinel ecosystem today? Sort of, do people have tools deployed? Are they pulling anything out of the note? So that was sort of one set of activities. And then the other was really starting to look at what information was available within the note. And so again, if you're going to do an analysis and you're going to look at the totality of somebody's clinical record, that's going to give you sort of one view versus if you're looking at just hospital discharge summaries or pathology reports or things like that. So we just wanted to start to look at what is some of the variation that we see when we extract information from a note. And then the final objective here was really trying to pull it all together and just sort of what are some of the best practices out there for how to represent information derived from unstructured text within a common data model. So that was really our major focus. We go to the next slide. So the first objective, really just understanding what is important. And so what we basically said, we want to identify priority concepts, data domains, data elements. I'm going to kind of use those interchangeably. To bootstrap that process, we took a list of the commonly used natural language pipelines that are out there, both sort of commercial and open source that kind of publish their dictionaries, if you will. Generated a list of broad categories or classes, and then just sort of once we got a good enough list, we passed that off to FDA, asked them to identify anything that's missing, assign priority rankings, and then really with the highest priority giving to sort of concepts that are not easily obtainable in claims, but are also important for drug safety studies. And just to give an example, sort of how this looks like in practice. So this is an example of a note that is sort of some sample notes where basically the NLP tool has gone through and highlighted certain data elements, certain concepts within the note. And so the kinds of things that you see sort of underlined and bolded at the bottom are the types of things that are extracted out of the NLP tools. So we went through that priority process. If we go to the next slide, and this is just a subset of what was there. So we had the concepts from sort of the existing tools, and that's the top table. And again, these are just some of these, just some of the rankings. And so again, with the highest priority given to those things that are sort of not well represented in administrative claims, yet important for drug safety studies, some information around cancer, site histology procedure, signs and symptoms from conditions, medical history, things like medication class are less important because that can be sort of inferred from other things. And then you can see some of the concepts at the bottom table, sort of not standard across all tools, yet still important for Sentinel analyses: timing and duration of medications, physical findings, drug indications, oxygen support. It sort of came up from many of the COVID studies, and then in sort of death information, because that's not always highly reliable across data partners. So that's just an example of some of the priority concepts. So we go to the next slide. So the next step was really understanding around like what tools are in use and then how are they being used. And so we generated a partner that we distributed, or generated a survey that we distributed to partners within the Sentinel ecosystem to assess capability. And so we sent it to Sentinel data partners and then a number of partners within the Innovation Center. We got a total of 17 responses. And of those 17, we found sort of 12 were using natural language processing in some capacity. 50% were sort of project-specific research, would be for like some of the projects that you saw today, where there's sort of a faculty that's interested in using the tool. But then another for sort of general research or operational purposes, which you could take to be, an institution has a data warehouse, they process all the notes through NLP, and sort of those are available for for general purposes. So that was sort of good information. A wide variety of tools that were being used and the notes that were being processed, both in the type of notes and sort of the number of years. And so a fair amount of variability there, which we sort of expected, but we just wanted to get a sense. And then the other thing that we found is that the scope of concepts that are being extracted also varied quite widely. I think 9 of the 12 reported being able to extract diagnoses, and that was really the highest percentage. And then sort of a handful of other concepts were sort of being extracted by 50% of the respondents. You can see it here in the graph. Cancer site and histology, smoking status, signs and symptoms, treatments and procedures. So some of those were in wider use, but again, a fair amount of variability, which just helps us sort of understand the state of the state, if you will. So the next slide. And so the next set of tasks that we did was really trying to understand kind of what information was available in a note. And the motivation behind this particular exercise was sort of thinking about a future state of Sentinel and really the health data ecosystem in general. So we know that natural language processing pipelines increasingly advertise as sort of commodity software as a service offerings from cloud providers. So you can go to Amazon Web Services or Microsoft Azure, and there's a NLP service that you can run on your clinical note for sort of pennies on the note. So if you were to imagine a future state where you've processed your 100 million notes through these tools and everything has been annotated, so what kind of information could we expect to find from the text? And so that was really sort of the motivation. And so what we did is working with 2 annotation partners at Mass General and at Vanderbilt. We worked through sort of 2 use cases that were identified through this prioritization process. So one was just looking at hospitalized patients with COVID-19 and sort of an emphasis on documenting the use of supplemental oxygen. And then another was around cancer, and this was just sort of choosing patients with a new order for Darzalex. And the rationale for the cancer use case was if we start annotating some of the information that's in the note, could we actually use that to determine sort of the indication behind the prescription? If there's sort of 1 of 4 reasons why somebody might be on this particular drug, would we have enough information in the unstructured text or structured text plus unstructured text to really figure out which of those 4 categories were applicable? So if we go to the next slide. So there's a whole lot of text on this. I'm not going to text on this slide. I won't go through everything. I'll just say in terms of the methods, we came up with an algorithm to define a cohort and sort of a sampling strategy to pull out the notes. Some pseudocode was given to each of the partners to help them identify patients. And then we created an annotation guide that the teams would use to basically help them go through the note and annotate the different concepts or data elements that existed within the note. And so the annotation guide, there's a sort of a snapshot up from the top, and then sort of the annotations themselves. An example is on the bottom right there, where you might highlight chest pain as an example of a condition, for instance, and you could say it's a sort of a positive assertion, and then sort of it's a current condition. And so we went through to find different classes we would annotate, and then attributes around sort of positive mentions, current, historical, things like that. And then in addition, we could highlight relationships between classes. So there's a medication, and then there's a dose that's mentioned, or a medication and an indication. And so we went through that exercise to define the guide and then sort of the process for annotation itself. So if we go to next slide. So just a couple of, just to highlight a few of the results, won't go through this in much detail at all. Just one of the things I wanted to highlight in the COVID use case was really, we found mentions of oxygen support in the sort of class of patients that have documented supplemental oxygen billing codes, but then the bottom graph is actually the cohort of patients that did not have a billing code for supplemental oxygen. And what you could see is over half of the patients in each of those cohorts actually had a positive mention of oxygen support. And so just again, the variation that we see in the undercoding with billing codes. We go to the next slide. And then with the cancer use case, I think the main thing with the cancer use case is we had variation in the type of notes that were selected. And you can see in the sort of top middle, the number of annotations between Mass General and Vanderbilt. Vanderbilt had sort of oncology notes written by physicians assistants, and practitioners, and Mass General had a more of a variation in the notes and the note types. Very different totals of annotations, 1,300 versus 1,700, and then just differences in the type of sort of information that was documented within each of them. So again, just the variation that can come out from the different notes that are processed. And then I think we go to the next slide, sort of final slide. And then the last sort of objective that we're attempting to tackle related to sort of best practices for representing structured information. Hopefully this slide will pop up here in a second. But just thinking about the process from taking source data, processing it through an NLP pipeline, you've got outputs that come out, and then sort of information passed on to the common data model. One of the objectives that we're working on is a literature review, just looking at performance characteristics of NLP pipelines. Second is just sort of documenting considerations on translating NLP outputs into derived features. And then third is around the structure of sort of common data model itself. And then I think I go ahead and thank my collaborators. The slides are not advancing for me. It might just be my screen that's frozen. But I'll just say team at Vanderbilt, Brigham and Women's, and then sort of FDA and Harvard Pilgrim. So thanks.
Hi, I guess I can get started with the last presentation. This is talking about tree scan past and future directions. The next slide, please. So the first task order from the signal detection and analytics pillar of the Sentinel Innovation Center was a systematic review that was led by Josh Smith at Vanderbilt. And in this systematic review, he summarized the published literature, trying to understand where the key areas for methods development are when it comes to EHR-based safety signal identification for Sentinel. And one of the areas that was identified as in need of further development was a tree scan-based methodology. Next slide, please. So what is tree scan? Tree scan is a statistical data mining tool for signal detection. The trademarked tool is a publicly available software that implements tree-based scan statistic methodology. And tree-based scan statistics are a methodology that address issues with multiple testing when you're doing hypothesis-free screening of thousands of potential adverse events. Next slide, please. It's important to note that the methodology that tree scan software implements is only the first step for active drug safety surveillance. Tree-based scan statistic methods can be used to identify potential signals by generating statistical alerts and narrowing down focus to events of high interest. Those potential signals can then be refined through tailored studies to investigate specific outcomes or through evaluation of targeted patient profiles in relation to those alerts. And potential signals can be thoroughly evaluated, confirmed or refuted with full protocol-based studies. Next slide. So how has tree scan been used before? There's been a variety of tree-based scan statistic methods that have been applied with different types of study designs as well as use cases. There's a non-exhaustive list of prior studies shown on this slide. For example, there's been a series of studies that have used tree scan with a self-controlled design for hypothesis-free screening and surveillance of vaccine safety. There have been a few studies that have used tree scan with a case control design for drug scanning or screening of potential targets for drug repurposing. In terms of cohort studies, there have been a few that have compared an active drug of interest to non-user cohorts. But more recently, tree scan has been applied with an active comparator new user design with propensity score matching for evaluation of drug safety. And I'll touch on a few of the studies that I'm more familiar with. Next slide. So the performance of tree scan with the active comparator new user design was evaluated via simulation to try and illustrate the performance in terms of power and type 1 error when you're screening thousands of hierarchically aggregated outcomes. And this study used simulation to show how the statistical alerting patterns can light up different areas of the tree because of the co-occurrence of clinically related outcome nodes. Next. In another paper, the performance of alternative generalized propensity scores to provide confounding control across a wide range of outcomes was evaluated in a series of empirical examples. General propensity scores are required in the hypothesis-free screening context because it's not feasible to pick and include tailored risk factors for every possible outcome that's being screened. So this paper also demonstrated some of the steps in active surveillance with an empirical example that started with using tree-based scan statistics as a first step to identify statistical alerts. The handful of alerts that arose from the analysis were then evaluated from clinical and methodologic perspectives, and the investigative team chose to move forward with refining understanding of one unexpected alert with a tailored protocol-based study, as well as a clinician review of patient profiles, using the patient episode profiler tool that is produced by the Sentinel Operations Center. These additional analyses at the refinement stage led to refutation of the unexpected statistical alert that was identified in the screening phase. Next. So TreeScan with an active comparator and user design was put into practice in a diabetes studies that compared SGLT2 inhibitors to either DPP4 inhibitor or GLP-1 agonists. And this study screened over 10,000 outcomes in an ICD-9 digit-based tree and found only 2 statistical alerts. Those alerts were for genital infections and ketoacidosis, which were 2 adverse events that were already expected to occur more often for initiators of SGLT2. Next. Similarly, TreeScan with the active comparator and user design was used to screen for adverse outcomes in 2 case studies of drug exposures during pregnancy. One of these case studies screened over 10,000 outcome nodes across the entire range of ICD-9 codes, looking at the relationship between opioid exposure in the 3rd trimester particularly. The other case study focused on valproate exposure in the 1st trimester and screened a tree of malformation outcomes with over 700 nodes. And so for these 2 examples in pregnancy, where the safety profile of the drugs were already well characterized, the statistical alerting patterns reflected expected signals. There was only one unexpected alert, which was for a specific malformation that had not previously been reported, but which there was some biologic plausibility for the relationship. Next slide, please. So that was a selected review of a few studies that have used TreeScan. And historically, TreeScan has been applied with studies that have used claims data. It's been used to evaluate binary or count outcomes, and the scan statistics have included the conditional and unconditional binomial, Poisson, or tree temporal scan statistics. The outcome trees have typically used hierarchies defined by ICD-9, ICD-10, or multi-level clinical classification of the ICD-9 or 10 codes. But moving forward, especially as Sentinel builds its linked claims EHR assets, tree-based scan statistic methodology and software can be developed to allow hypothesis-free screening of the types of data available in EHRs. So there's a non-trivial task of pre-processing clinical notes and mapping both the extracted terms and information from the structured fields to a common hierarchical ontology such as MEDRA. Scan statistics need to be developed to allow simultaneous screening of different outcome types, such as continuous outcomes based on labs or vital signs. Additionally, hierarchical ontologies such as MEDRA and SNOMED-CT have characteristics that differ from ICD-based trees, and this will require some adaptation of the way that the data is processed and the inputs are created for statistical software to carry out the scanning analyses. Next slide. I don't want to dive too far into the weeds, but to give a high-level overview of the types of adjustment that we would need to accommodate, I'll briefly discuss the hierarchical trees that are used for tree-based scan statistics. Now, theoretically, any hierarchical classification system can be used with tree-based scan statistics, including systems that have a single pathway for aggregating codes and those that have multi-axial pathways. Next slide, please. For example, trees based on ICD-9 or 10 have a single pathway for aggregating the diagnosis code. You can see an example of that pathway traced in red on the left-hand figure shown on this slide. And for various reasons, the trademarked TreeScan software requires that the investigator provide outcome counts at the most specific leaf level, and this is usually the diagnosis code. The counts are then aggregated by the software into the parent nodes. But patient ID is not retained or processed, so the software cannot deduplicate outcome counts as they're aggregated up the tree. So if a patient had both 75731 and 75732, these would be counted as 2 outcomes in the corresponding parent node instead of 1 unique outcome. Next. So to address this, there's a couple of data preprocessing steps that can be taken. For example, you can define incidents at the highest level you want to test and apply a washout to remove the possibility of duplicates. Or you can feed the software leaf nodes based on the unique combination of codes that are experienced by a patient and add this as a new leaf layer for the tree. This would also allow the nodes to be aggregated without double counting. Next. But if we want to scan across outcome trees that incorporate both NLP extracted terms and structured clinical codes that are mapped to MedDRA, we need to expand the capacity of software to meet our new analytic needs. As I mentioned before, trees such as MedDRA or SNOMED are multi-axial, which means that each clinical concept can be aggregated along multiple paths, and that makes it impossible to pre-process the data in a way that's compatible with existing software to define incidents at a particular level or to feed it a leaf node based on unique combinations. But these aren't issues with the statistical methodology behind TreeScan. These are just new considerations that need to be addressed in terms of pre-processing different types of data to be compatible with the hierarchical trees that have different characteristics from the traditional diagnosis-based trees that are used when analyzing claims data. Next. So move on to a high-level discussion of scan statistics. Scan statistics evaluate a null hypothesis that there are no outcomes in the tree for which there's an effective exposure against an alternative hypothesis that there's at least one outcome for which there's an increased risk with exposure. So the first step is to pick which test statistic to use. For example, one test statistic that has been used in many of the active comparator user design analyses is the unconditional Bernoulli scan statistic. And this test statistic involves calculating the log likelihood ratio for each node based on the number of cases in the treatment group, the number of cases in the comparator, and the probability of being in the treatment group. The test statistic in the observed data is then the most extreme value across all nodes of the tree. Could you go to the next slide? Okay, so after you pick the test statistic, basically you need to pick an alerting threshold and use Monte Carlo simulation to generate p-values given that the distribution of this test statistic is unknown. And in terms of interpretation, the statistical alert is not necessarily a safety signal. It's only the first step and always requires further investigation and refinement. Next slide. So there's a couple of different, that was just a general overview, and there's different scan statistics that need to be developed to accommodate continuous outcomes. These could be approximating binomial or Poisson tests with Gaussian likelihoods, or using things that are on the same scale, such as standardized mean differences or nominal p-values. Next slide, please. So just to summarize, some of the future enhancements that are planned with tree-based scan statistics using the linked claims EHR infrastructure for Sentinel. First, we need to develop a portable pipeline to produce outcome data for a hierarchical tree that brings together structured data, NLP, labs, and vital signs. Second, we need to develop scan statistics that can simultaneously evaluate binary count and continuous outcomes. Third, we need to develop software or data processing procedures that can handle multi-axial pathways with hierarchical trees. And fourth, as a proof of concept, we'd like to test this enhanced methodology and software procedures in some examples using linked claims and EHR data. And for the last slide, could you click one time? All of the activities discussed today feed back into the key objective of the Innovation Center, which, as you've heard, aims to work in close collaboration with the Operations Center to expand FDA's ARIA capabilities and deliver a query-ready, quality-checked distributed data network that includes at least 10 million lives with EHR data. Thanks.
Thank you all very much. Thank you to all of our presenters. Thank you, Shirley, for the wonderful last presentation of this session. I do want to add that Colin Walsh is in fact the Associate Professor of Biomedical Informatics, Medicine and Psychiatry at Vanderbilt University. I initially said Assistant Professor, that is Associate Professor. So again, thank you to our panelists. I think we have time for just one question in the Q&A that's likely of general interest to our audiences. To the panelists, are there plans on the roadmap to make the data discussed today available to the public and or other research groups?
Yes, I can take that question. Thank you, Rachel. So the data itself contains, of course, patient identifiers. And with NLP type of data, that's more of a concern because it's really hard to scrape off the patient identifier. So individual patient level data, I don't think will be available anytime soon for full sharing. However, all our work, all our algorithm developments that are ongoing as well as completed are deposited to publicly to GitHub and should be accessible to anybody who is interested in replicating any of this work through Sentinel GitHub.
you. I think we can ask perhaps one more question in our last minute for the panel. We're curious to hear the panel's perspectives on a question that came up in the chat that I think Sebastian answered on the heterogeneity of unstructured data between and within EHR databases and implications to natural language processing augmented or based phenotype development strategies. Can someone on the panel talk more about that if there's time? I think
Let
we've
me
got
just
about 1
start
minute.
out, and then somebody of informaticians can follow up on that. Clearly, that's something that we recognize, that care is provided differently. We have different EHR systems. There's tremendous heterogeneity, and we need to acknowledge that. Hence, any ML-derived algorithms need to be tested with regard to their transportability between the systems. We need to understand how well they can be transported. And there's a tremendous amount of research ongoing within, not only within the Innovation Center, but outside of the Innovation Center. This is very exciting research and needs to be solved in order for this to be successful. Anybody else wants to chime in here?
This is David. I could say it's constantly on our minds because we're thinking about the transportability of this work, and generally simpler approaches have fewer problems in this regard. You know, the fewer assumptions you make about what's going on in the text, what kind of section it's in, what type of note it's in, the fewer heterogeneity issues you have.
Well, thank you so much. I think we are at time to move to our next session. Thank you all again for the wonderful presentations for our kickoff session for today. It's my pleasure to introduce our next session, focused on best innovations in data infrastructure and analytic methods. For this session, we'll explore linkages across real-world data sources to improve COVID-19 vaccine exposure and an application of the linked data in a COVID-19 study. We'll also consider a COVID-19 vaccine effectiveness study in nursing homes and a benefit risk assessment framework on potential risks associated with myocarditis or pericarditis following COVID-19 vaccination. So as I introduce our panelists, to those of you who may not already be on camera with your microphones on, please do so. Our panelists for this session are John Seeger, Chief Scientific Officer at Optum, Bradley Layton, Senior Research Epidemiologist at RTI Health Solutions, Young Liu, who's a mathematical statistician and real-world evidence reviewer working for the FDA's CBER and Office of Biostatistics and Pharmacovigilance, as well as the Analytics and Benefit Risk Assessment team. Lastly, we're joined by Rich Forshee, Acting Deputy Director at the Office of Biostatistics and Epidemiology in CBER. So without further ado, I will let our panelists move into their presentations. Thank you. John, take it from here.
All right, thank you. Let's see, double check that I'm not muted. Yes. Okay. Hi, everyone. Good afternoon. I'm John Seeger, Chief Scientific Officer for Epidemiology at Optum, and I'm based in Boston. And I'd like to start by framing some of the discussion around this idea that really is sort of a rationale for Sentinel, and that is if a drug or a vaccine has an effect, whether it's beneficial or adverse, that effect should show up in routine healthcare. And that the sorts of databases that we've been talking about, claims or electronic medical records, as repositories of routine healthcare, can be mined to discern those beneficial or adverse effects. That said, though, it's not easy. It's really challenging to do that and separate the noise from the signal. And there's sort of the framework that Trish Bright outlined of establishing population and then exposure, outcome, and covariates, and then an analysis provides a guidance for that. And my presentation today, I'd like to focus on the exposure part of that framework, and particularly the exposure to the COVID-19 vaccine. And if you're thinking about using that exposure information to conduct a comparative concurrent cohort study of vaccinated and unvaccinated people. Can we move to the next slide, please? Sort of a framework of the data generating mechanism. It starts with a patient having some encounter with a healthcare system, and then there's a cascade that will lead to sort of electronic fingerprints being placed in an electronic medical record or in a claims that becomes part of a database that can be used for research. And last year I did a presentation here talking about the red box area here, which is where we've used the Optum data structure, where Optum has a large health insurance claims database as well as an electronic medical record database, but we're focusing on the claims database where we were bypassing some of the adjudication process so that we were using pre-adjudicated claims to help speed the responses that we can get through our research. And so that's relevant to what we're going to be talking about today, is using pre-adjudicated claims and then trying to improve the capture of vaccine administrations. And then on the right in this figure, I have you can put together then claims and or electronic medical record encounters in a way that is a patient timeline, and so you can use that to help be a foundation for your inferences about the effects of drugs or vaccines. Let's go to the next slide. And so this is an example of that kind of sequential listing of claims that a person has. I particularly selected patient who had a COVID vaccine, and I selected the time frame of 1 month before and 1 month after that COVID vaccine. And so what you can see is this person appears to have some diabetes. They receive medications or continuous glucose monitor related to diabetes, but they also receive the COVID vaccine. You have, say, day 0, there's a mass vaccination site, and also there's a pharmacy claim coming that reflects the vaccine administration on that date. And then you see a few weeks later, the person has another dose of the same vaccine. So there's a claim sequence. The concern was, though, because these vaccines, the COVID vaccines were free, there may be less incentive to record the encounter and produce a claim. That's sort of the only way we know that this person actually received the vaccine if we're using a claims database. And so let's go to the next slide. So we did a tabulation of all the different sites that vaccines were received. And you can see, this may reflect some of your own experiences with receipt of COVID vaccines, pharmacies, doctors' offices, and then mass vaccination or mass immunization centers. And there's certainly some claims that are coming from each of these sites that are tabulated. But what we don't know is, are the mass vaccination or other sites substantially under recording the claims that for the vaccines they're administering? And so we next slide, please. We sought to see if we could enhance the claims data through external data linkage. And this is just an illustration of hypothetical numbers of vaccinated patients with the COVID vaccine, and then whether or not they developed a subsequent COVID-19 diagnosis. And so in my original table here, I have, this is assuming there's a 70% vaccine effectiveness. This is how the numbers would work out, and that the incidence of COVID among unvaccinated patients is 6%. That 70%, though, if there's a 50% misclassification of patients who are vaccinated as unvaccinated, and that's the table to the right, where I've just taken the vaccinated patients and half of them move them down to the unvaccinated category. It's non-differential with respect to whether or not the patient subsequently develops a COVID vaccine or a COVID diagnosis. What would happen is that 70% original number would change to a 49% vaccine effectiveness, and that's just an artifact of this misclassification of vaccine status. And so the question was, how could we address this? And you might say, well, that 50% misclassification looks really bad, and that seems unreasonable. But it may be close to what it actually is. So let's go to the next slide. So this is just a background on immunization information systems. It's a set of it's a system that sort of developed in response to an epidemic in the late 80s, early 90s, and now it's coordinated by CDC, but administered locally, state and local levels. Next slide. And so when we started this project, it turned out United Health, which is the parent company for Optum, had already been contacting a number of these sites because this is for healthcare operations purposes. But once we really ramped up, I learned the benefits of being part of a large company as Optum. We could have a dedicated team to outreach to each of the different sites, because each one had to be contacted separately, and then you have separate contracts and agreements to review from each of those, and then you also have to have data infrastructure and technology for transfer of files, so that we send a roster of patients from the claims from the insurer to the sites, and then they do a linkage behind the scenes and then send it back to us, and then we link it back to our research database. Can you go to the next slide? Okay, and then each of the different sites are somewhat different, and you can see the linkage process is actually unique to each site. They have their own list of variables that they use to do the linkage between what we send them and what they have in their database, and then they send us back a file. Let's go to the next slide. Okay, this is, and it's showing once we've done all of that process, we have these 11 sites. This is a little bit older data. Now, currently we're close to 30, but these 11 sites give us, and they're from 14 different IIS, because some states have more than a single IIS. But you can see there's quite a benefit to adding the IAS, which is in blue, to the claims, which is in green, and so that the average increase is shown in the table below. About 46.7 was 46.7, but it's not so far off of what my hypothetical number was to begin with, so showing that there is substantial underreporting of vaccination through the claims alone. Let's go to the next slide. But certainly it's not complete to have just claims and IIS, because there may be other people who don't have either of those, and so we were trying to estimate how much is being missed from either. So we use 3 different approaches: age standardized CDC estimates, age standardized State Department of Health, and then a capture-recapture database driven approach. Next slide. And then through each of these, each of the different sites also have different age groups, and so we have to standardize differently for each of those sites. Let's go to the next slide. And we get different sensitivity estimates for each jurisdiction, and then you can see the 3 different external reference groups: the CDC, the Department of Health, and the capture-recapture. But they all give us a pretty tight range of sensitivity estimates for the combined claims and IIS data. And so then we can take those numbers and put it, go to the next slide, as a back into our the 2x2 table, and correct it using really straightforward algebraic methods to get an updated vaccine effectiveness estimate. Okay, all right, that will take me to the next slide, which is basically thanking my collaborators on this. Really took even a larger team than we have here, but I'd like to also say that there are extensions. This is now a foundation that's going to keep going, and there are ways to expand it to include other vaccines, and a lot of that work is ongoing. And I'd like to close it now and pass it on to the next presenter.
Hello, my name is Bradley Layton. I'm a director of epidemiology at RTI Health Solutions. And I'm really pleased today to be following John talking about a really good case example of the importance of having these linked claims data and IIS data for an evaluation of the effectiveness of COVID-19 vaccination in the United States. Next, please. So as an employee of RTI Health Solutions, I've been involved in a lot of COVID-19 related research with a lot of different groups, but the project that we'll be discussing today was done within the BEST Initiative Network. Next, please. Next. So it will come as no surprise to anyone assembled here that COVID-19 has really spurred the development of numerous new vaccines that have been authorized in the United States. And as part of its regulatory mandate, FDA needs to evaluate the effectiveness and the safety of these vaccines. But given the really rapidly changing landscape of both COVID-19 infection and vaccine development and subsequent authorizations, there are a lot of different types of questions. It's not as simple as just asking what is the effectiveness. And so there were multiple questions beyond just a simple estimate of overall effectiveness, things like potential waning effectiveness over time or effectiveness versus new variants. And then as there have been kind of subsequent authorizations for additional doses and booster doses and updated booster doses and in different age groups, there are a lot of different questions. And so as we discussed with our partners within the BEST system and within FDA, how best to address this topic, we landed on an approach kind of built on target trial emulation methodology with a really strong causal inference foundation, but that required differentiation between vaccinated individuals and unvaccinated individuals. And so these conversations were happening at the same time as the conversations that Dr. Seeger was just presented on were happening. And so recognizing the importance of these claims linked with IAS records to more accurately identify vaccination status, that became the perfect place to implement this study. So next slide, please. Next. So I'll be giving just a brief overview of our approach here. The protocol is publicly posted on the BEST Initiative website if you'd like to go into more detail. And I will note that we won't be discussing results today. There are various different work streams within this project in various states of completion, and we hope to move into the dissemination phase very, very soon. But just as an overview, the primary objectives of this study were really based in the primary series of the vaccine, that first 1 or 2 dose series that we received. And you can see here on top that the primary objective was to compare receiving a complete primary series versus being unvaccinated. And so in that, there's a couple layers to unpack, that we need to be able to identify individuals who are vaccinated. We need to identify whether they have completed that primary series, which means being able to accurately identify all the doses they received and the timing of those doses. And then we need to be able to reliably identify unvaccinated individuals. And so that required really better data on vaccination status than many of us thought we had at the time. And then you can see on the second primary objective, there are these questions that we discussed earlier, these questions of waning effectiveness over time or across different eras of circulating variants. And so these questions required an approach that account for kind of time varying status, and that required the methodologies that we were discussing earlier, these ability to identify individuals at the time they first received their vaccine and then be able to follow them over time and look at changes over time and potential different vaccination strategies and pathways. Next slide, please. As you can probably imagine, the nature of the study has changed as rapidly as the pandemic has changed. And so there are multiple secondary objectives, and we won't go into all of the details here. Some of them are standard things like looking within subgroups of special interest. There's also a comparative effectiveness aim where we identify individuals receiving complete primary series of the different vaccines and then compare them to one another. But then, as I mentioned, these are multi-dose series, and there's multiple ways to kind of complete a series or not complete a series. And so we have some additional analyses looking at kind of alternative vaccination strategies, things like receiving only a single dose of a 2-dose primary series. Lastly, this was all, this kind of started after the first authorizations of vaccines, where we're looking primarily in adults, and then subsequent vaccinations in children required kind of a separate pediatric analysis. And then lastly, after we began kind of the initial study, obviously we have additional layers of booster and additional doses. And so we added an additional objective looking at a booster dose. And this has a slightly different characteristic to it, where we're looking at individuals who receive booster doses after a complete primary series, compared with individuals who received a complete primary series without a booster dose. So this requires, again, identifying all of the doses of a primary series and then being able to accurately identify a booster dose and then classify someone as having not received a booster dose. Next, please. Next. So this is just a very brief overview, but as was just presented, we're using these linked pre-adjudicated claims from Optum with the IIS registries. And this gave us the ability that we kind of built in the backbone of the claims data, where we identified individuals and all their characteristics, but then used the linked data to identify all of their vaccine doses. Apologies for the typo. I noticed it after the slides went out, but the study period began on the 11th of December, 2020, the first day that vaccines were available in the United States. And as John just mentioned, there are a lot of moving parts in here, and these different databases have different kind of refresh schedules and linkages. And so for different analyses, the end time of the study period kind of varies based on what was the latest data available at the time of extraction for that particular data set. And that could vary by IIS. Next, please. So this study is really built on three distinct cohorts that are identified in slightly different ways. The first, where most of the analyses are occurring, is the adult primary series analysis on the left in the blue box. This identifies individuals at their first vaccine they received, and then follows them forward in time. And then we identify a matched set of unvaccinated individuals at on the same calendar day. And then on that backbone of identifying individuals at their first vaccine, we have several other analyses based within that same framework of identifying the primary series. The second, the middle box, is the pediatric primary series. This feels very similar, except because there were the kind of rolling authorizations for different age groups, we are identifying individuals who are aged within an authorized age group at the time that it was authorized. So we have this kind of additional kind of chunked calendar time by age group. Then lastly, we have the booster or additional dose analysis. This, as I described before, is all within individuals who have a complete primary series. Then we're identifying vaccinated and or boosted and unboosted individuals matched on calendar date. Next slide, please. Just as an example of how one of these works, looking at the adult primary series, we identify all individuals on the date of their first observed vaccine dose during the study period. We call that time 0, their first vaccine dose. And then on that day, on that same calendar time, we identify an unvaccinated individual who was eligible to be vaccinated but wasn't. And because this varied so much across time, across jurisdictions, we couldn't kind of explicitly define who was eligible and not. So we used this approach where we matched individuals on age and geography and other demographic characteristics, but also clinical characteristics that would cause people to be prioritized for vaccination. And so we ran this matching algorithm on each day of the calendar of the study period. So at the end, we had a vaccinated group and an unvaccinated group who were balanced and matched on all of these characteristics. Next, please. And so, as I mentioned, we're identifying people at dose 1, but we want to know whether or not they received their complete primary series. And so we started follow-up on time 0, the day of their first vaccine. And then if they received a vaccine series that was supposed to have 2 doses, we identified whether they received their second dose within an authorized window. And then if they did, then follow-up continued and they were considered adherent to the primary series. If by the end of that window they hadn't received the dose, they were censored because they were no longer adherent to receiving the primary series. We identified COVID-19 outcomes in medical diagnosis claims during follow-up. Next, please. Then just as an overall measure of vaccine effectiveness, we calculated a hazard ratio and calculated VE as 1 minus the hazard ratio. But as I mentioned, we had all these questions about changes over time, and that required a slightly different approach. So to address those, we plotted cumulative incidence curves of COVID-19 outcomes over time. There's a hypothetical example there shown on the right. And this gives us a daily estimate of the risk of COVID-19 in the vaccinated group and the unvaccinated group aligned on time since vaccination, or since time 0. And so doing that, we can calculate daily estimates of the risk ratio and the risk difference at all of these time points. And we can calculate it then as the daily VEs as 1 minus the risk ratio, and really evaluate how the risk ratio or the VE changes over time. We can use this to evaluate potential waning effectiveness, like shown in the next slide. And you can plot this over time to evaluate since vaccination, how does that, you wouldn't expect much at the beginning. This is just hypothetical data. And then as your body mounts an immune response, the VE would increase. And then over time, we might observe potential waning effectiveness. And then we can disentangle this also by variant era to disentangle the effects of waning effectiveness since vaccination, and also by calendar time and variant era. Next, please. So that's just a really quick overview. Next. But we really wanted to provide an example of why these linked data were so important. To answer the objectives, we really needed both great data on vaccination status in order to apply the methods that we needed to. We will acknowledge that there are still potential sources of bias despite using the data sources and the methods that we did. And so our study involves numerous sensitivity analyses, negative control analyses, and quantitative bias analyses. And so thanks again. Sorry we didn't get to touch on results, but we expect to see those very soon. And on the last slide, I just want to acknowledge my collaborators within RTI International, and then our collaborators within the BEST initiative at FDA and within Optum and Acumen. next. And thanks so much for your attention. I look forward to the discussion.
Good afternoon, everyone. My name is Yun Lu from FDA CBER. Today, I'm going to present results from real-world data to estimate effectiveness of mRNA COVID-19 vaccines for nursing home residents 65 years and older. This is the joint work of FDA, Centers for Medicare and Medicaid Services, and Acumen. Next slide, please. This is my disclaimer. Next slide, please. The COVID-19 pandemic disproportionately impacted older adults, especially nursing home residents. It's important to study the real-world effectiveness of mRNA vaccines among this vulnerable population. Next slide, please. The observation period was from December 13th, 2020 to November 20th, 2021, right after the emergency use authorization of the first COVID-19 vaccine and before the circulation of Omicron variant. From the breathless talk, you can see that their study period started December 11th, 2020. That was the day of the EUA. But for us, we chose a Sunday, December 13th, to be consistent with the CDC's week definition, so we could use their Delta variant circulation data. We included both Pfizer and Moderna mRNA vaccines, and we allowed individuals to switch vaccination cohort. So the exposure is time-varying mRNA COVID-19 vaccination status. And our study population included Medicare fee-for-service beneficiaries, 60 years and older, living in nursing homes. Exposure and outcomes were identified using health claims code in the Medicare system. The primary outcomes were severe COVID-19 outcomes, such as COVID-19 related deaths and COVID-19 hospitalizations. Next slide, please. FDA CBER have studied influenza vaccine effectiveness among community dwelling Medicare beneficiaries for a decade. But this is our first time conducting vaccine effectiveness study among nursing home residents in order to better understand the population and evaluate potential risk factors to severe COVID-19 outcomes. We conducted COVID-19 natural history study among nursing home residents in the pre-vaccine period. We have observed significant differences between long-term stay and short-term stay nursing home residents. We have found that individual level characteristics, nursing home level characteristics, geographical characteristics were all associated with COVID-19 outcomes. Based on our natural history study results, we have decided to perform the vaccine effectiveness study among long-term stay nursing home residents. Starting from our base population of long-term stay nursing home Medicare beneficiaries, we applied inclusion and exclusion criteria, which enabled us to adequately capture measured covariates. Next slide, please. Underreporting of COVID-19 vaccination status has been an issue in medical claims data. You have also heard that from John. The underreporting of the primary series COVID-19 vaccine was less severe among nursing home residents than the community dwelling beneficiaries, because there are pharmacy partners went to nursing homes and administered primary series of COVID-19 vaccines. In the study planning stage, we conducted quantitative bias analysis to evaluate the impact of underreporting of vaccination. This is the feasibility study. We want to evaluate whether we'll be able to conduct absolute vaccine effect study. Because of the underreporting in nursing home is not very severe, we have concluded that, yes, we can move forward with the absolute vaccine effect study. And to further reduce exposure mystification, nursing homes with low vaccination rate before March 1st, 2021 were excluded. We also exclude beneficiaries with missing preceding dose. Next slide, please. This is our final study population. 348,000 long-term stay nursing home residents, 65 years and older. Beneficiaries were allowed to switch cohorts, so vaccination cohorts varied over time. By the end of the study period, November 20th, 2021, 61% of them were in the 2-dose cohort, followed by 21% in the booster cohort and 14% in unvaccinated cohort. Please note that this percent did not reflect percentile. Next slide, please. Based on our COVID-19 natural history study results, the measured coverage include individual level characteristics, nursing home level characteristics, geographical level characteristics, as well as time variables such as local COVID-19 circulation rates and the Delta variant rates. To ensure that the vaccine cohorts were comparable, we compared cohort balance for the measured covariates, and we used inverse probability treatment weighting, IPTW, to address imbalance in all measured covariates. Following IPTW, there was some residual imbalance remained for influenza vaccination and the prior COVID-19 infection status. Next slide, please. Next slide. Because there are still some remaining imbalance in the covariate after IPTW, we also adopt a doubly robust approach by including all covariate in both the weighting and outcome mode. Next slide, please. Here is the crude unweighted COVID-19 death and hospitalization outcome result. I want to show you that for the crude outcome, you can see that the 2-dose and the booster dose have significantly lower rate compared with unvaxxed and 1-dose. And also for the hospitalization outcome, the rate was lower compared with death outcome. Based on our natural history study, we observed that there are many COVID-19 deaths without prior hospitalization among nursing home residents, which is different from the pattern we observed from community dwelling. So caution need to be taken when interpret hospitalization outcome result among nursing home residents. Next slide, please. This slide showed our main result for COVID-19 related to deaths by time variant Delta share and the COVID-19 circulation rate, all using vaccinated cohort as the reference group. The 2-dose VE were showed in black, booster dose VE showed in color. So we can see booster dose VE was significantly higher than the 2-dose VE, suggesting the added benefit of booster dose. And the 2-dose VE were lower during the 99% Delta than the 0% Delta period. But the 0% Delta period always happened before the 99% Delta. So the effect of the increase in the Delta share and the potential waning effects cannot be separated for this study period. So both likely contribute to what we observed, the decrease in effectiveness in the higher Delta period. We also observed that the VE was higher during the high COVID-19 circulation period. It's probably because of the false positive COVID outcome could result in the underestimation of the VE, especially for the low COVID-19 circulation period. And this was consistent with our finding when we conducted the influenza VE study for the past decade. Next slide, please. The hospitalization outcome result is very similar to the death outcome, with the exception that the selected model did not include interaction term of COVID-19 circulation rate. Next slide, please. So when comparing VE for death and hospitalization, VE for death was higher and less impacted by the change in Delta variant share or waning immunity than hospitalization. Next slide, please. So this study has some strengths. This was a very large COVID-19 vaccine effect study using real-world data for one of the most vulnerable populations, nursing home residents. And we also incorporate nursing home residents characteristics. Okay, yeah. Okay, so next slide, please. I'll skip the limitation, go to the conclusion. Next slide, please. Okay, in summary, booster dose V was significantly higher than 2-dose V, and the 2-dose V were lower during the 99% delta than the 0% delta period. The waning immunity may have contributed to the finding. And the V for deaths was higher and less impacted by the change in delta variant share, waning immunity than hospitalization. And the observed real-world V was potentially more accurate during the high COVID-19 circulation than the low COVID-19 circulation period. Next slide, please. Okay, so this is the acknowledgement slide. I want to thank all the FDA, CMS, and Acumen team members. And I will hand this over to the next speaker, Dr. Rich Boshi. Thank you.
Thank you, Yan, and thanks also to John and Bradley for setting up this presentation so well. In my time, I'm going to talk about how we've used some real-world evidence that's been generated through the BEST initiative in order to support decision-making at the FDA. Next slide, please. This is my disclaimer. Next slide, please. So the FDA benefit risk framework takes into account 4 dimensions when we're evaluating the benefit risk balance of a medical product, in this case, a vaccine. The dimensions are the analysis of the condition, the current treatment options, the benefit, and the risk and risk management. Across each one of these dimensions, we consider the evidence and the uncertainties, and the review team is asked to provide its conclusions regarding that dimension, as well as the reasons that led to that conclusion. The first 2 dimensions can roughly be mapped onto the therapeutic context, and the final 2 can be roughly mapped onto the product profile of the product under consideration. Next slide, please. It's very common when conducting benefit risk assessment to need real-world evidence in order to be able to characterize some of the inputs that need to be used in the analysis. As most of the people on this call know, the 21st Century Cures Act asks the FDA to put additional focus on the use of real-world data and real-world evidence, and we've tried to take that to heart at the FDA. Just a couple of bits of terminology that I want to get clear. Real-world data is the term that we use for data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. And some of those are listed here. And really all 3 of our speakers have spoken to this some in the previous presentations. What I just want to emphasize is that from all 3 of the previous speakers and from my work here, it's very, very important that anyone trying to generate real-world evidence have a deep understanding of the data that they are using. One of the points that I'll mention in a little bit is the reminder that real-world data was not collected for the kind of research that we wish to do on it, or the kind of public health surveillance that we may wish to use that for. And so in order to draw valid inferences from it, we have to know how that data were generated and the implications of that for the way that we analyze it. Real-world evidence then is the clinical evidence regarding the usage, potential benefits or risks of a medical product that's derived from the analysis of RWD. And we have guidance that's available on the use of real-world data and real-world evidence. Next slide, please. In the rest of this presentation, I'm going to be talking about a benefit risk assessment that was conducted for the COVID-19 mRNA vaccine developed by Pfizer BioNTech. And specifically, we're going to be looking at the authorization for age 16 to 29 years. And this has been published in the journal Vaccine earlier this year. Next slide, please. Next slide. Thank you. So going through the 4 dimensions of the FDA benefit risk framework, under analysis of condition, the key points are at the time of the analysis in August 2021, there had been more than 200 million cases and more than 4 million deaths worldwide from COVID-19, and that 90% of the cases were among age 16 years or older. Next slide, please. At the time the analysis was conducted in terms of current treatment options, there were no licensed vaccines or antiviral drugs for COVID-19. There were emergency use authorizations in place for 3 vaccines, Pfizer, Moderna, and Janssen, Pfizer for 16 plus, Moderna and Janssen for 18 plus years of age. Next slide, please. We had some good data on the benefit of the vaccine. The vaccine efficacy against confirmed and severe COVID-19 after dose 2 was 90% and 95% respectively from the clinical trials. However, the real-world vaccine protection against disease depends on both the COVID-19 incidence and the circulating virus strains. As both Bradley and Yun discussed in previous presentations, there is some reason to believe that effectiveness of the vaccines declined over time, but it's difficult to determine how much of that was waning of effectiveness after the vaccination versus how much of it was a changing of the circulating strains. Next slide, please. Under risks and risk management, in the clinical trials, there were no notable serious adverse events or deaths related to vaccination. However, with post-market surveillance, we became aware of an elevated myocarditis, pericarditis case rate, and this was a low rate, but enough to be a clinically significant risk, and the risk seemed to be higher among male adolescents. And the management options that we had to consider included providing information on this on the product label, additional post-market safety surveillance, or a post-market requirement or commitment. Next slide, please. So we considered this to be a decision that was consequential enough and that was close enough in terms of evaluating the benefits and risks that it warranted a quantitative benefit risk assessment. We had some uncertainty in the benefits. Part of that uncertainty was what the dynamics of the pandemic were going to be. Obviously, if you have a higher circulation rate, an effective vaccine will prevent more cases and more severe outcomes than if the circulation rate is very low. We also had some uncertainty regarding the Delta variant that was emerging at that time. We didn't have direct evidence of the vaccine effectiveness at the time of against Delta at the time of the analysis. And we also had to consider the possibility that there was waning of vaccine protection. We also had, on the risk side, we had to focus on what was the risk of myocarditis, pericarditis, and particularly among male adolescents, where the benefit risk balance could be closer than in other age sex groups. Next slide, please. So to conduct the analysis, we began by developing a value tree to identify the key benefits and risks that we were going to consider for the analysis. On the benefit side, we wanted to consider how many, for the vaccine, we wanted to consider how many COVID cases, hospitalizations, intensive care unit admissions, and COVID-19 deaths would likely be prevented by the use of the vaccine among the different age sex groups. The risks that we considered focused on the myocarditis, pericarditis, and so we estimated the excess myocarditis, pericarditis cases, hospitalizations, and deaths. Next slide, please. So I want to emphasize again why real-world data and real-world evidence were important for this and many other benefit risk assessments that we conduct. So the vaccine benefit is going to depend on the disease incidence, and we needed to understand effectiveness in real world and effectiveness changes due to emerging new variants and waning of immunity. Next slide, please. So we got these results from a number of places, but I'm going to focus on the use of BEST for the myocarditis, pericarditis rate. We needed data on this. We needed data from the US, and BEST allowed us to quickly develop appropriate estimates for those key risks for our benefit risk assessment. Next slide, please. I'm going to skip this slide in the interest of time. So next slide, please. One of the issues that we faced in doing the analysis was that at the time that we were conducting the analysis, the latest data that we had on trends in COVID-19 cases was in early July, when cases, we were at a very low point in terms of COVID-19 cases. But we knew that cases were beginning to pick up, and we knew that a new variant was beginning to circulate. So we needed to make assumptions about the appropriate rate. Next slide, please. So we approached this by using two different scenarios for the COVID-19 case incidence and hospitalization rate. One that we call the pessimistic scenario, because it would yield a lower benefit to risk ratio, used the July 10th, 2021 rate. But knowing that the rates were increasing, we also conducted a most likely scenario using 10 times the July 10 rate for incidence and 4 times that rate for hospitalization. Next slide, please. So this shows the results for the most likely scenario. And the point to note is that the benefit risk balance overwhelmingly favors vaccination for males 16 to 17-year-old, with many fewer myocarditis, pericarditis cases, hospitalizations, and deaths compared to what would be prevented by the vaccination. Next slide, please. This shows the pessimistic scenario where the balance is closer. The vaccination still prevents vastly more COVID-19 cases than there might have been myocarditis, pericarditis cases caused. It also prevents more ICU stays and deaths. But we did estimate that there would be more COVID-19 hospitalizations compared to myocarditis, pericarditis hospitalizations. It's important to note, though, that the myocarditis, pericarditis hospitalizations tended to be short stays, usually 1 day, and were typically for observation, whereas the COVID-19 hospitalizations were more severe. Thus, we believed that the benefits still outweighed the risks under the pessimistic scenario for males 16 to 17. Next slide, please. So concluding this, looking at the direct benefits in terms of reduction of COVID-19 cases, hospital stays, ICU admissions, and deaths, the benefits outweighed the risks, even in the pessimistic scenario that we modeled. We used real-world evidence in order to get estimates of the myocarditis and pericarditis risk. We tried to use sensitivity analyses to understand the uncertainty of the risk across different age groups, and long-term studies are underway. The final decision was that the known and potential benefits outweigh the known and potential risks, and licensure was approved in November 2021. I'm near the end of the presentation. Next slide, please. Yes, I'll just end with a photo from the White Oak campus on one of our benches. This is from a court case insisting that the FDA insists reality matters. Thank you very much, and I look forward to the rest of the discussion.
Thank you very much, Rich, for the wonderful presentation. Thank you to all of our panelists for this session. We learned a lot today about what we might, or what's in store for us moving forward, things that we should think about. We have a question from the audience, actually, that touches on this a bit. I'll ask all of our panelists to please come on camera as we move into our discussion, our Q&A discussion with you all. Thanks again for the excellent presentations. To our audience, as a reminder, you can submit questions through the Q&A function at the bottom of your Zoom window. So we'll look out for some of your questions for our panelists here for this session. So I want to talk about what we should think about moving forward. A question from an audience member asks, moving forward, in anticipation of future pandemics, where mass vaccination centers will be utilized, have there been efforts to improve the standardization of immunization data collection and linkage between various EHR and claims databases in the US?
So I'll start this off and then others can jump in. Yes, there have been efforts. No, we don't have a perfect solution in place yet. One of the things that we have really advanced is collaboration with the IIS jurisdictions. Both John described this in some detail in his presentation, and that's really helping our ability to capture the vaccine doses that are administered. FDA is also in close communication with CDC, and we are exploring ways that we can do a better job of capturing this in the future. I think it is important to note that at the time we were in a crisis, and the most important thing was to get the vaccine to people who needed it. And so while it's unfortunate that we didn't capture all of that data, it was more important that the vaccinations be delivered promptly. So I think I'll leave my comments there and see if anyone else wants to add to that.
Yeah, this is John. I'd like to add to what Rich just mentioned, which is certainly, from my perspective, that between claims and IIS, we're at 71% on average, sensitivity of vaccine capture, and that, we know how to deal with that. We have a mechanism now for dealing with it, but it would be useful if it was higher. And but beyond just the overall capture through claims or the IIS system, some standardization or speeding up of the process so that we can use it in closer to real time would help. And so those are just some thoughts, but I mean, certainly if there are improvements, that will improve what we do, but we know how to use what we have.
Hi, and this is Bradley. I'll just jump in quickly on a related note, that this issue became really pronounced during the pandemic, where we realized that we were missing lots of these vaccines that were given out very quickly. But I'll note that this issue is larger than just in pandemic situations, where there are plenty of vaccines that are given out in public health departments and public health clinics, and routine children's vaccines that are given out in vaccines for children, or states with vaccine for children programs that don't necessarily always make it into claims data also. So, I mean, this is an effort that could really improve not just kind of pandemic related vaccine questions, but just routine research into vaccines.
Yeah, and I want to add that for nursing home residents, the system captured the primary series of vaccination pretty well. And also, there is public available information from CDC and CMS that enable us to compare our claims data with the public available information. That also helps us tremendously when we evaluate the impact of underreporting vaccination data.
Responses. In fact, I want to probably dig in a little more into challenges associated with linking data sources. So thinking about how you linked administrative data to immunization data to publicly available data. What are some specific challenges that come to mind that we can probably think more about and address in the near term?
So again, I'll go ahead and start, and then I'm sure that others will have things to add. there have been a lot of challenges in trying to link the data from the IIS jurisdictions with our data partners. One arises from the fact that there are more than 60 IIS jurisdictions, and each data partner needs to make arrangements with each jurisdiction in order to start the data exchange. It's easy to do the math, and you quickly get up to hundreds of legal agreements that need to be put in place. In addition to that, the IIS jurisdictions are overburdened, and they now have multiple entities asking to work with them on sharing data, and oftentimes the requests are just a little different, but enough to cause problems for the IIS jurisdiction. And then finally, there are each IIS jurisdiction is affected by both federal and state laws. And in some cases, IIS jurisdictions interpreted their state laws saying that they could not share these data with some of our data partners. So those are some of the issues that I've observed, and I'll turn it over to my colleagues now.
Yeah, this is John. I'd like to add to what Rich just said. I certainly echo all of the things he mentioned. Just we've seen them firsthand. But the the other thing that I would add is around Optum and United Health have really sort of strict guidance on patient privacy, and we should always recognize that we're sharing confidential patient information through these kinds of linkage processes. And so some systems to manage that, I mean, certainly in the work we do, I have no access to patients' identifiers, and none of my research team has access to it. There's a separate team that does have access to it because that's what's needed to share. But yeah, so some work around privacy and ways to share that retain privacy would be helpful.
And I'd like to just build on what John said. I want to emphasize that the FDA never sees this personally identifiable data. One of the principles that we used in establishing the best system is that the data stay with the data partners. And we work with the data partners to establish a protocol for an analysis, and we see the aggregated statistical results from that analysis. And then John's already described some of the internal mechanisms that they have to protect patient privacy. So we all take this very seriously, and it's something that we think is incredibly important.
And if I can say something maybe just a little downstream of the actual mechanics of the linkage and getting the process in place. I mean, once we have the linked data, I know it's something that Optum went through quite heavily, and we talked about quite a bit, as about deduplicating records that exist in multiple data sources, about ensuring that if you get multiple records of a particular claim from different sources, they come with different levels of granularity. Some are explicitly labeled as a first, a second, or booster dose, and some aren't. And so there's a lot of methodologic decisions you have to make about how you actually define each dose, about what information from what source that you can use. And as John pointed out in his presentation, even with the linked data, you notice there was information that was in claims that wasn't in IS, and vice versa. And then comparing it to multiple different potential gold standards, and we realized that there wasn't a gold standard. I mean, CDC had an estimate of coverage that was different than the individual state health departments, and then the capture recapture methods kind of all gave slightly different versions. So it's not like there is a gold standard where you ever know that you really have caught all of the records at this point. And so there's still a lot of assumptions that happen even after the linkage.
Now, all of that being said, now I kind of want to switch it to priorities that we can discuss perhaps around improving data linkages, and even thinking along that vein about ways in which we can tap into other data sources that might even create more robust data linkages. What are your thoughts there now that we've discussed the challenges? Let's flip it on its head and talk about some of the opportunities that are ahead for improving data linkage and data robustness through linkage.
Does someone else want to start?
I mean, certainly I can head off, start with a few thoughts that I have. Having sort of pressure tested this kind of surveillance within the setting of a pandemic, all the things we've learned can be applied to routine surveillance. Helping the Center for Biologics Effectiveness and Research fulfill their mandate of monitoring the safety and effectiveness of the products they regulate, and so that this is good. It's sort of like a car company developing a race car and pressure testing it in the context of race, and then you can then they can advertise the routine drive from home to work is made safer or more efficient by some of the testing they do in the context of a challenging situation.
Yun, would you like to talk a little bit about some of the work that we did with the Medicare current beneficiary surveys, another example of linking to external data sources?
Yes, I will provide my perspective. So we have been conducting researches using the Medicare data for over 10 years. And we have learned that when we use claims data, there are many coverage that are not available. One practice we did was we're linking the data with the medical current beneficiary survey. So the survey was a representative sample of the Medicare population. It contains some additional information, for example, about health-seeking behavior, about frailty. We'll be able to link the survey with our data. But the challenge is only 0.1 to 0.2% of the Medicare beneficiaries contained in the survey. But the missing algorithm is missing at random. So we're able to conduct multiple interpretation. But at the same time, because of the low percentage, it also increased uncertainty in the estimate. But what we have found out is when we can use the IPTW, the propensity score weighting using measured covariates actually also helped with the balance for the unmeasured covariates in the health claim system, but we will be able to capture that in the survey data. So basically, we have seen that using the approach doing weighting, it helped us improve the cohort balance, even for the cohorts that are not measured in the claims data. And also for the nursing home data, we not only use the claims data, we also have other data that could measure some facility level characteristics and also additional individual level characteristics. That help us tremendously because we not only can control for individual level characteristics, we can also control for facility level characteristics simultaneously. We also linked our data. We also use the CDC data. Basically, you can see we align our weak definition with CDC that allow us to use the Delta strain circulation, the weekly data, for us to evaluate the time variant impact of the Delta variant. So by linking our data with other data source, it helps us control for the measured or unmeasured confoundings and also help us to create more balanced, comparable cohort.
Yes, and I would just add that in some of our Medicare work, we've been able to link data at all the way down to the census block level in some cases. And being able to use data at such small geographic units helps us to ensure some better balance of so many of the factors that vary across geographic areas in the United States, from social determinants of health to the kinds of access to healthcare facilities. So all of these examples show how linking to external data can help you assess the reliability of the data that you're using, and oftentimes bring in other information that can help with the analysis. And the last thing I'll say here is that the Medicare current beneficiary survey is fantastic because it gives you a window into how much you've reduced unmeasured confounding. And similar sorts of projects with some of our other data partners could be useful. I don't want to assign new work to John, but again, we've found the current beneficiary survey to be very helpful for our work. Thanks.
Thanks again. So Jan, I want to talk a little bit about some things you mentioned in your presentation, or things that you spun some ideas around, I should say, particularly around the use of negative controls. We've been thinking a lot within our real world evidence group about key issues that are forefront for improving causal inference. So do you have any thoughts on some opportunities or challenges for identifying bias in observational data as we consider that as a source, a negative control source, potentially in some cases?
For negative controls, actually for PDUFA 7, there is a very specific section about negative controls. So FDA CBER will develop a methodology project that would utilize double negative control to improve vaccine effectiveness study, because there are unmeasured confounders. So we hope to use the negative control pairs, negative control exposure, and negative control outcome to adjust for unmeasured confounding. So we have used negative control outcome in our previous studies. For example, for our zoster vaccine effectiveness study, we used negative control outcome, or we call it falsification outcome. Those are not related to zoster vaccines. So in theory, we should not detect any association. So we have 13 falsification outcomes. We want to see whether they centered around one and whether there are any patterns. For our influenza vaccine effectiveness study, we also use some of the negative controls to help us detect whether there's any residual confounding. But the challenge is there is no one-size-fits-all solution, because we need to understand our data very well. And for each of the research question and the regular question, because the data source could be different, because the source of biases could be different, then the choice of negative control and negative control pairs are very challenging. So basically, we'll need to work together and collaborate. And based on the existing scientific knowledge, and also based on our understanding of the data. So basically, there are opportunities. At the same time, it's a very challenging task. Real world evidence is a new area. I think people are working together to move this forward. Thank you. And Rich, do you have anything to add?
No, Yin, I think you covered that very well.
So much. I do have a question from the audience. Someone asked, linking to publicly funded IISs is a known complexity as we learned during the H1N1 outbreak in 2009 and now relearned during COVID. What can we do to establish routine IIS linkages to claims in health systems so the data are timely and able to promote public health in real time?
Yeah, this is John. I can give a start and certainly pass it on to others, but I maybe didn't have time in my presentation to make the point, but the infrastructure that we've built, I think, is planned to continue, and that we will then have the claims linked to IIS on an ongoing basis, so that it can be used for either other epidemics or pandemics, or for just routine surveillance, and then any enhancements to the completeness of that will only make it better. But I think I'd have to defer though to folks from the FDA of are they how they plan to use that for going forward. But certainly the infrastructure is there.
Yeah, so I would agree with John that we've already made some important advances there by establishing relationships with many of the between many of the data partners in IIS jurisdictions. And we're continuing with a lot of effort in that area to see if there are more that we can add and to make sure that all of the data partners have similar success to where Optum is at the moment. So that's one thing that we can do with the resources that we have. I think some of the other questions about a more universal fix for this are a little bit above my pay grade, as they say. But you know, I've certainly been talking with anyone who would listen to me about this for a couple of years now, and I would certainly love to see you know, more fundamental solutions to make sure that all of the appropriate people in the federal government who could benefit from further information about vaccination status while protecting patient privacy were able to get that. Thanks.
So much. All right, well, I can actually, while we have you, Rich, question for you. So in your presentation, you mentioned that whenever you apply a risk-benefit framework, there are inherent trade-offs. So how did BEST inform the risk-benefit framework from this point of view for the myocarditis and pericarditis study?
So BEST had a tremendous contribution because they were able to provide information on the myocarditis, pericarditis rates by age, sex categories, which let us do specific analyses for the groups that had the highest myocarditis, pericarditis risks, which let us do the benefit risk comparison for the group that might be at the highest risk. And we still concluded that the benefits outweighed the risks even there. So being able to get that data and being able to get that data in the time that we needed it in order to make our regulatory decision was critically important for that analysis. And I think another issue that I mentioned was that we were trying our best to compare cases to cases, hospitalizations to hospitalizations, and deaths to deaths. But even in that situation, they're not always perfectly comparable. And so having information from multiple real world data sources that helped us better characterize what a myocarditis, pericarditis hospitalization looked like compared to what a COVID-19 hospitalization looked like in the specific age groups allowed us to better understand the trade-off that we were looking at in that particular case. Just one last thing I want to add about this. There are also long-term studies that are ongoing looking at individuals who had myocarditis, pericarditis following COVID-19 vaccination. And so we aren't just looking at what happened in the immediate aftermath, but both FDA and CDC are working to look into the long-term outcomes so that we will have a final, more complete understanding of that risk. Rochelle, I see there's another question in the Q&A. I'd be happy to take a stab at that. Okay, it looks like we might have some technical difficulties, so I will go ahead and try and address this last question in the Q&A, and I know we're just about out of time. So the question is, given the availability of vaccines and therapeutics for COVID and the need to monitor safety of each using very similar data and methods, how is FDA coordinating efforts to promote efficiency? So as part of our BEST initiative, we have both a coordinating center and we have a center that is working on community outreach and development. And so through this, we are both coordinating and being able to share lessons learned with all of the analyses that we are doing, while also reaching out to the broader community of people who are working in this area so that we can share what we've done and we can learn from what others in the community have already tried. So I think that how I would summarize what we're doing to try to gain some efficiency here. Does anyone else on the panel have anything they'd like to add?
Maybe I can't speak from the FDA perspective, but I will say, so many things happened so quickly at the beginning of the pandemic, and there was rushes to put lots of things into place. And I certainly appreciate the sentiment behind this, that you have the FDA is doing its surveillance work, companies are doing their own past studies, often multiple of them in multiple different jurisdictions. And so there is a lot of concurrent work being done on relatively the same topic in many of the same data sources kind of concurrently. And so I can see there is a lot of kind of acute burden placed on some of these data sources here. So yes, I think a lot of it is just owing to the urgency with which many of these studies were initiated early in the pandemic.
Wonderful. Thanks, everyone. I experienced a minor Zoom crash, so thanks for carrying the conversation. My next question was going to be the one that we saw in the chat or the Q&A, so thank you for answering that. I assume you did. And we are actually going to move forward and wrap up this session. Thank you again for this excellent discussion. We will now be taking a break for about 10 minutes and we'll reconvene at 2:50 p.m. Eastern for our event's final session, focused on key collaborations with stakeholders and development of new partnerships in the Sentinel Initiative. So we'll see you all in a few minutes. And for this next session after the break, I should note that Tanisha Carino, who is a visiting fellow at the Duke-Margolis Center for Health Policy, will be moderating. So thank you all again for your engagement and for being a part of our audience. And I hope you enjoyed the rest of the workshop.
Okay. So welcome back, everyone who's joined us today. I'm Tanisha Carino. Among many hats that I wear, I'm also a visiting fellow at the Duke-Margolis Center for Health Policy. I'm pleased to be moderating this last session of the 14th Annual Sentinel Initiative Public Workshop. Mark McClellan, who's the director of the Duke-Margolis Center, will be back with us after this session and will be providing some closing remarks. So let's proceed with our panel, where we'll hear about how the Sentinel Initiative is developing and expanding partnerships with diverse stakeholders and key collaborators. In this panel, we're going to cover ongoing work by the Sentinel System's Community Building and Outreach Center to engage with the stakeholder community. We'll also be hearing about a new partnership that's been developed by the Sentinel System and the Centers for Disease Control and Prevention to conduct public health disease prevention reporting. And finally, a new collaboration between the BEST system and the eHealth Exchange to develop new data sources and analytic capabilities for automating adverse event reporting. As I introduce our panelists, I'll ask them to turn on their cameras. Our panelists for this session include Margaret Anderson, Managing Director at Deloitte, who leads the Community Building and Outreach Center of the Sentinel System. Grace Marks, Medical Epidemiologist at the Centers for Disease Control and Prevention. Eric Heflin, Software Architect and Technology Consultant for the eHealth Exchange. And Lance Jones, Lead Data Scientist at IBM. Thank you to all of our panelists for joining today. Margaret, if you don't mind, take it away.
Thank you, everyone. I'm excited to be here. And again, my name, as Tanisha said, is Margaret Anderson. I'm a managing director at Deloitte in the federal health area. Pardon the background noise. I'm en route to a trip. So I work in the federal health sector. Today I'll be speaking on behalf of the Community Building and Outreach Center, commonly known as CBOC. So the CBOC supports FDA Sentinel, and I plan to use our time today to help you learn more about that initiative, why it's important, and how it may impact you. Next slide, please. So here's a preview of our agenda. Today, I have 4 items I wanted to specifically speak with you about. First is talking about the history and the purpose of CBOC and the strategic aims we support. Then I'll talk about the projects and the activities tied to the CBOC master plan and the goals and outcomes of those projects. I'll then cover projects that we've recently completed for the CBOC and projects that are ongoing. And then I'll spotlight a featured project. Next slide, please. So the CBOC was created, in a sense, to broaden and activate a strong scientific community to advance the Sentinel initiative. It supports the FDA in accomplishing 3 of the strategic aims outlined in the Sentinel System 5-year strategy, 2019 to 2013. These aims are reflected in the recommendations and projects outlined in the CBOC master plan, which will be discussed in our next slide. The aims are threefold: to use the Sentinel system to accelerate that access and broaden the use of RWD and RWE, broaden the Sentinel system's user base to pursue the vision of the national resource, and then, kind of disseminate and get that knowledge out there and advance regulatory science. Next slide, please. So this slide illustrates the CBOC master plan, and if you've heard me present or heard us present on this, you probably are familiar with some of these things. What I'll do is talk about some of the sort of current state projects and things that are in play. So that master plan was developed to focus on engagement and awareness of Sentinel, and it identifies stakeholder priorities, outlines a set of projects, describes that action plan, and proposes methods to evaluate project impact. So the projects within the plan are twofold, and you see here communications and training, which is inclusive of projects to kind of create educational materials, updates on Sentinel and the activities. And then the second piece is around bidirectional engagement and how we can increase the ways that stakeholders use the Sentinel infrastructure and tools. So these projects are implemented by the CBOC to increase awareness of the Sentinel initiative and system design, build up an understanding of Sentinel tools and infrastructure through training, and enable stakeholder contribution to the Sentinel community. So next, we'll take a look at some of the projects that we've completed, those that are in progress, and those that will be accomplished in the future. So if you could go to the next slide, please. So, this slide really looks at those master plan accomplishments. 7 CBOC master plan projects were implemented or are in progress to increase awareness of Sentinel and the design of the Sentinel system. These projects are also intended to improve usability of the Sentinel tools and infrastructure and increase stakeholder contribution to the Sentinel community. So I'll start with the Sentinel website redesign and implementation. Hopefully you all have taken a look at this. Release 4.0, a refresh of the Sentinel website, was deployed in April with a new featured tab to showcase activities in key topical areas, specifically looking at COVID-19, pediatrics, and pregnancy. And the CBOC also conducted regular Drupal updates, in addition to many other website operations and maintenance requests from the SOC and the SCT. Overall impact of this, I'll say, is we've really optimized user interface and user experience of the Sentinel website, with over 1,000 updated web pages that allow stakeholders to better locate resources and stay informed with Sentinel. So next, we have a quarterly public-facing newsletter. We encourage you to sign up for this. We encourage you to take a look, forward it to other people. This is the quarterly newsletter that highlights the developments within the Sentinel system. And this year, it included a redesign of the newsletter in a new modern format to help readers navigate content more easily. 3 newsletters were released so far in 2022, with the 4th quarter scheduled in December. And we've got a lot of promotional efforts that have increased the number of subscribers for now almost a total of 6,000 subscribers. So next, I'll talk about the webinar series. So the webinar series is, we hosted 2 so far this year. The first, which was an overview of the Sentinel website for health advocates that provided information on the basics of Sentinel for non-technical users. And the second being an overview of Sentinel's publicly available tools. This covered the common data model and routine querying tools for the more technically inclined. The impact of this is that it increased visibility of Sentinel within stakeholder groups, including informaticists, epidemiologists, and health advocates, and we've reached over 300 new participants. So the next slide will feature additional CBOC master plan accomplishments that occurred in 2022. If you want to go to that next slide, please. So the virtual training series that you see here, this is a video that instructs audiences on how to use a data visualization platform known as Sentinel Views. The impact of this is that we've provided kind of more clarity and support to over 100 participants. You have here also templates, standardized presentations, informational videos. We've really been working hard on this with the entire team, and we've got over 300 online views. Some details there, the major moments in the development of Sentinel uploaded to YouTube and the website, where you can understand the origins, the foundational principles, and design decisions that inform Sentinel. And then the Sentinel user base also uploaded to YouTube and the website. So also there's another one on understanding the Sentinel common data model. So a lot of materials there. I hope that you will, kind of take a look and explore. Importantly, share these resources and let people know that these are available. There's other videos available and other materials on the Sentinel for research and public health surveillance, as well as the strengths and limits of EHR data sources and claims. You also see up here the data sandbox support. So CBOC completed 2 projects that were the Data Sandbox Technical Discovery Project. This included the development of optimal users and use cases for the Data Sandbox in collaboration with the Innovation Center. And then the CBOC Data Sandbox Engagement Strategy Report, which was a comprehensive report on the user engagement methods aligned with each user or use case identified by technical discovery. So the impact of this is that we developed a comprehensive and individualized engagement strategy for marketing the potential data sandbox projects to reach the identified user groups and their corresponding use cases. Last but not least on this, you see graphics. These are, we've done these in ongoing CBOC 2-week sprint cycle. We've created and maintained over 50 graphics for publication on the Sentinel website. So next we'll do a deep dive on a featured CBOC project that occurred in 2022, and this is the CBOC Analytic Tools webinar. So we held our second webinar. This was titled An Overview of Sentinel's Publicly Available Analytics Tools in September of this year. The recording and slides are on the Sentinel website and the Sentinel YouTube channel. The webinar had over 250 individuals registered, and then we actually had 129 attend. We had 9 agencies represented, including HRSA, CMS, CDC, NIH, and EPA. 150 private organizations were represented, including many major pharma and health services companies. And the webinar covered key components of the SCDM, the different types of Sentinel routine querying tools, and how to access both of these resources on the Sentinel website. So in closing, thank you for listening to the CBOC updates. I hope it gave you a more granular understanding of our efforts, and I will pass the baton to the next speaker, Tanisha. Thank you for the introduction and look forward to the rest of the presentations.
Thanks, Margaret. Grace, I think you're up next.
All right. And I believe someone else is sharing their slides, but correct me if that's incorrect. There we go. All right, great. Thank you. Glad to be here today. My name is Grace Marks. I'm a medical epidemiologist with CDC's Division of Vector-Borne Diseases. And today I'll be talking to you about our use of FDA's Sentinel system to surveil Lyme disease post-exposure prophylaxis. Next slide, please. So just for a bit of background for folks who aren't Lyme disease experts, this is a very common vector-borne bacterial disease. In fact, the most common vector-borne disease in the United States. As you can see on the right, there's increasing incidence over time in the past several decades, likely due to increased risk of exposure to tick bites, given reforestation and suburbanization. The number of reported cases each year is really between about 30 and 40,000. You can see the most recent trends there in the graph, but this is almost certainly an underreporting. Next, please. So as I mentioned, only a fraction of cases are reported. Next, please. In fact, we think that given recent data that we've pulled together in our group, probably closer to 500,000 cases are diagnosed and treated annually in the United States. Next slide. So transmission of Lyme disease is via a bite of an infected black-legged tick. You can see the ticks there on the bottom with a close-up of a dime just to give you a sense about how small these ticks are. They're very tiny. Next slide. So in the United States, the epidemiology is very interesting. It's a highly geographically focal disease. The vast majority of disease occurs in just 15 states. As you can see on the right in the map that shows one blue dot for each reported case of Lyme disease, the vast majority of cases occur in the Northeast, the Mid-Atlantic, and the Upper Midwest. There are some cases that occur each year on the West Coast due to the related tick vector Ixodes pacificus. There is expansion of Lyme disease. You can see increasing incidence over the past several years in neighboring states of these high incidence areas. And again, as I mentioned, it's driven by multiple factors, including climate change and increased tick exposure due to a behavioral change as well. Next slide. Seasonality of Lyme disease is very critical to understand. Again, it's transmitted by the bite of an infected tick, so it requires that ticks be active for transmission to occur. As you can see in the graph on the lower right, which shows number of cases by month of disease onset, the vast majority of cases occur in the mid-summer months following the activity of the nymphal tick. The adult Ixodes tick is also active in the fall, mostly in October and November, but those ticks are larger and easier to see and often are removed before transmission of the spirochete can occur. Next slide. So when we think about prevention of Lyme disease, we often think about the things that are listed there on the right, which is kind of a flyer that's available on the CDC website. Of course, we think about repellent, checking for ticks, showering after being outdoors, and then of course, notifying your healthcare provider if you have a fever or a rash. Next slide. However, there's also the availability of post-exposure prophylaxis. So we know that Lyme disease can be prevented by a single dose of doxycycline, which is a common antibiotic, when it's taken within 72 hours of a high-risk tick bite. Next slide. The only recommended regimen for Lyme disease prevention, and again, this is for people who are asymptomatic, who don't have symptoms consistent with Lyme disease, but after these high-risk tick bites, is a single dose of doxycycline. Next slide. So the regimens are outlined here by age category. So in the first row there, adults, the recommended dose is a 200 milligram dose of oral doxycycline. So typically 2 pills. Doxy typically comes in a 100 milligram tablet or pill. And then for children weighing less than about 100 pounds or 45 kilos, the recommendation is also a single dose of doxycycline, but that is weight-based. Next slide. Almost all other indications for doxycycline require multiple consecutive days of twice daily dosing. And this is important when we think about the methods that were used for this particular effort. Next slide. So again, a little bit of context here about what options are available to us as we think about the patterns of post-exposure prophylaxis for Lyme disease. So unlike Lyme disease, which of course is a nationally notifiable disease, tick bites are not notifiable. So CDC has very little insight into who is being bitten, when they're being bitten, and what they do about it. Next slide. So as I mentioned, Lyme disease PEP is prescribed, again, to patients who are asymptomatic and when laboratory testing is not appropriate. So this is people who had a recent tick bite, don't have any symptoms. Even if they were infected with the Borrelia-Burgdorferi spirochete, which causes Lyme disease, laboratory testing wouldn't be positive so early in the disease course. There wouldn't be antibodies that have developed at that stage. Next slide. So as a result, laboratory-based surveillance is not helpful. Next. And also we don't have the luxury of using things like diagnostic codes to inform the epidemiology of Lyme disease post-exposure prophylaxis. There is no ICD code for tick bite, for example. Next slide. So the goals of this project were to describe single-dose doxycycline pharmacy dispensings so that we might better understand. Next slide. Patient-seeking behavior, next. Geography and seasonality, people who are at high risk for Lyme disease, the healthcare burden of patients presenting after a tick bite, and finally, healthcare system dispensing patterns for Lyme disease prevention. Next slide. So as we were thinking more about this and even kind of exploring the feasibility of looking at single-dose doxycycline, whether it would be a reasonable proxy for Lyme disease prevention, we decided to do an initial evaluation using market scan data, which is available to us at CDC through a CDC agency-wide license. So as many folks know, market scan is also a distributed database of electronic medical records of primary beneficiaries of insurance and their dependents of employer-sponsored health insurance. However, it does have several limitations, including it excludes patients who are older than 64 years of age. It excludes recipients of government-sponsored insurance, and it also does not include people experiencing unemployment or their dependents. Next slide. Nonetheless, we were able to do this analysis looking at these few years of data, and we're able to identify that the majority of claims for single-dose doxycycline were for 200 milligrams, which does align with Lyme disease post-exposure prophylaxis. 6% were for 100 milligrams, which we think were again for a weight-based prescription of Lyme disease PEP. 2% were refills, and again, doxycycline is cheap, so the average cost to a patient was under $3. Next slide. And looking at seasonality was really important too for the reasons that I mentioned. And this is exactly the pattern that we would expect to see for Lyme disease post-exposure prophylaxis. Again, that big bump during the summer months, showing the nymphal tick activity when people are finding those attached nymphal ticks and coming in for post-exposure prophylaxis. But then also the bump in the fall, which represents active adult ticks when people might be coming in after an adult tick attachment. Next slide. So what are the benefits of using FDA Sentinel distributed database? Next. As I mentioned, there are several potential advantages, and this was really an opportunity for CDC to explore whether there would be additional benefit to looking at FDA Sentinel above and beyond a market scan, which I mentioned is readily available within our agency. The potential advantages are several, but I think 3 are highlighted here. One is that there's a larger sample size. The Sentinel distributed database includes national health insurance plans, regional integrated delivery systems, state Medicaid plan, and also Medicare fee-for-service, none of which were available through Market Scan. It also enabled a closer look about geographic information. We are particularly interested in looking at the distribution or the different patterns that are evident when you stratify state by Lyme disease incidence. So as I mentioned, there's 15 high incidence states, all the others are low incidence for Lyme disease. We wanted to look at the patterns of Lyme PEP by that incidence dichotomy. We're also interested in looking at urbanicity. And then, of course, as I mentioned, FDA Sentinel provided additional look at a greater diversity of patients, including older patients, older than 64, and also people with more diverse employment and insurance status. Next slide. So we built the design in close collaboration with FDA Sentinel and others, other partners. We looked at the period of 2009 through February of 2020, and then later expanded that through the end of 2020. The inclusion criteria were single-dose doxycycline pharmacy dispensing. And we were also interested in excluding doxycycline forms not consistent with PEP, and also people who received more than 1 day of doxycycline and people with an enrollment gap. Next slide. Again, it was an iterative process before we came up with our final query. Next slide. Next. So our objectives were to describe these dispensing patterns next. We were interested in the dispensing characteristics, the patient characteristics, and also the healthcare utilization patterns. Next slide. So what you can see here are the number of dispensings over time. We did see the number of post-exposure prophylaxis increase year to year. Next slide. Again, looking at seasonality, this is exactly what we had seen with the smaller study looking at market scan. Again, this bimodal distribution of seasonality of Lyme disease post-exposure prophylaxis. Next. Looking at patient characteristics, we did see a predominance of female patients and also people, primarily women who were non-Hispanic white. Next slide. And the majority of patients were older, again, emphasizing the importance of looking at this as opposed to something like a market scan. Next slide. The geographic distribution was consistent with Lyme disease incidence. Next. And again, stratifying by incidence of Lyme disease, we saw that the vast majority of dispensings were in states with high incidence of Lyme disease. Next slide. We did note some differences by urbanicity, with most dispensing occurring in either rural or suburban populations. Next. And most people did have a medical encounter within a week of dispensing, and about 50% had a diagnostic code for arthropod encounter. Again, all emphasizing that this is a good proxy for Lyme disease post-exposure prophylaxis. Next slide. We did some sensitivity analyses, which was fairly easy to do with Sentinel, and I won't go through the details here, but patterns were consistent with what we would have otherwise expected. Next. Next slide. Oh, sorry, go ahead, next. I'll just skip over to the next slide. So in conclusion, we did find that single-dose doxy dispensings closely mirror Lyme disease epidemiology. Next. And that PEP might be underprescribed for people at higher risk for Lyme disease, including children, people of color, and men. And importantly, we found that the results of this were important as we consider developing additional educational materials to increase patient awareness and clinician awareness of Lyme disease post-exposure prophylaxis. Next slide. And I think the most important thing, in addition to, I won't go through this for time considerations, but there were a couple of limitations to these data. Of course, generalizability being one of them, and also the fact that these data were not generated for insurance claims. And my last slide, next. Next. Last slide. Great. And I think just the main takeaway for CDC through this effort was that Sentinel was an important system that we can use above and beyond tick-borne diseases, but also to look at other emerging infectious diseases and other chronic diseases of public health concern, and that this is an important data that we can utilize and leverage for other purposes of the agency. Thank you very much. Back to you, Tanisha.
Grace, thank you so much. Next up, we'll be hearing from Eric.
Well, thank you very much. And thank you for having us come in today. So the health exchange is one way of thinking about it really is a secret weapon for public health. It provides a single connection to really the entire United States or very close to it, and provides near real-time quality assured data which can be used for public health as well as other purposes. I really want to thank the CBER group within the FDA, who actually was the really provided leadership for this project. So I'm going to talk about right now is just a few minutes about the Health Exchange for those that may have not have heard of us, and then talk about how we've partnered with the FDA and how we're also available to help others as well too. Next slide. So the Health Exchange is a 501c nonprofit charity. We were actually created by the Office of the National Coordinator, and in 2012, myself and one other person took over the effort and turned it into a nonprofit. And fast forward to today, and we actually have essentially connections to almost every major medical group in the United States, 50 states, 5 federal agencies, including the DoD, VA, Indian Health Services, FDA, and Social Security Administration. We also support other public health initiatives such as the AIMS platform for reportable conditions reporting as well too. Right now, as of today, we're exchanging around 12 billion transactions per year. And then, as Richard Forsey stated earlier today, that one of the objectives of the FDA, or at least one of the efforts being explored, is to acquire real-world data. And the Health Exchange really excels at making that real-world data available for authorized purposes, which includes public health. Next slide. So one way of thinking about the Health Exchange is it's a single connection to the entire eHealth Exchange network, which, as the prior slide showed, is around 75% to 95% of all hospitals in the United States, 85% of the dialysis centers, 61 state and regional HIEs, and then a number of federal agencies as well too. And this basically is done through one single connection. So the FDA, for example, when they connect to the Health Exchange, they do so through the Health Exchange Hub. It's one technical connection between the FDA and the hub. And then the hub actually acts as a proxy to talk to mediate, to translate, if necessary, between the FDA and all other data sources being used within the scope of this project. Next slide, please. Now, if you zoom out a little bit more, not only does the Health Exchange provide that kind of connectivity, but also the Health Exchange also connects to another 25 other networks as shown here, including Commonwealth, Care Quality, a number of vendor-specific networks as well too. And so when you count the connectivity up between the Health Exchange network and the other 25 networks we can connect to, we're approaching well over 90%, 95% of all hospitals in the United States, for example. Next slide. So what is the Health Exchange used for? There's a number of use cases, of which I'm showing a few here, that are our primary use cases for the Exchange. One of them is disaster response. Here in Texas, where we get hurricanes occasionally, the Health Exchange is used by HA Texas Pulse, for example, to query for evacuees being treated in alternate medical facilities such as football stadiums or churches or fairgrounds. It's also being used very commonly, the Health Exchanges, for treatment use cases, where a person is about to perhaps go into surgery and they want to pull up a list of the person's allergies. It's also used extensively for public health, but there is certainly a lot of additional use cases where we think we could help and would love to help public health achieve its missions. Right now for public health, the Exchange is being used for in pilot for CENER, which puts a API on top of hospitals, allowing them to share information about number of ventilators, things like that. Pulse for disaster response. For public health, for AIMS for reportable conditions, and of course the project we're talking about today, which is the FDA's CBER project for reportable follow-up on adverse events. Next slide. So the Health Exchange data, there's two main exchanges possible, as shown in the upper left-hand corner. One is where the initiator, such as the FDA, makes a query, such as they identify a given patient by demographics or hard identifiers or other characteristics. They do a query with a single connection to the Health Exchange Hub. The hub then queries the data holder, which is typically a hospital, but could be another agency and so on. And then the response is returned back to the hub, which is returned back potentially with modifications over to the FDA or another initiating participants. So that's a query responder workflow. And one of the things that I'm kind of excited about is we have a feature called geospatial encoding. And what this lets the Exchange Hub do is if, for example, the FDA says, well, okay, we have a patient who's seen in the state of, say, Florida, we would like to get information about all endpoints in the state of Florida, all data holders, all hospitals that have information on that patient. And so they actually can have the hub in the future broadcast that query out to, for example, everybody within cities where the patient has been known located, or the entire state or multiple states. So that's the first pattern. The second pattern is push. And in that pattern, what happens is the data holder perhaps has recognized that a reportable condition exists or an adverse event has been found, or candidate has been found. What they can do is actually take that adverse event and push the demographics over to the FDA or others as well too, indicating that something of potential interest has occurred. Moving down on the left-hand or left middle of the slide, commonly exchanged data formats include HL7 FHIR, which is an upcoming data format. HL7 CDA has been exchanged for many, many years. Of those 12 billion transactions I mentioned earlier, most of those currently are using HL7 CDA, consolidated CDA. But additional data formats are certainly allowed. The Exchange is content agnostic, and so we allow essentially any data format to be exchanged. Structured data can be exchanged as well as unstructured data. And the types of data that can be exchanged are shown on the right-hand side, which includes patients' problems, meds, allergies, lab results, vital signs. They can have unstructured notes such as progress notes. It also can include imaging reports, typically not imaging, the actual DICOM images, but the narrative reports, and then also history and physical, and much more information as well too. Next slide. One of the things that's the Exchange has invested heavily in, because we really think we're essentially, quality is our most important objective, and so we've invested very heavily for a little nonprofit on quality assurance, and so we actually have really a world-class quality assessment tool. And we know it's actually a unique tool because we actually found problems, for example, in the HL7 standards, and which they acknowledge, and we work with them to actually fix the problems in the base HL7 data content standards themselves. So the quality has several dimensions. One is we have mandatory metadata, and that's very important because what that allows for is privacy protection of the subject data, and also allows for automation. And so rather than having a network based on manual processes, our entire network is based on the premise that we're trying to automate all these workflows. In addition to quality, we check it for the structure of the data to make sure it's as expected. We make sure that the data is interoperable. We ensure that it's conformant, that the value sets are correct. And the bottom line is all these results work together to ensure that the data is reportable and can be used for things like analytics. Now, how we collaborated with the FDA is we actually work with them to gather their requirements. We did a survey of all 350 or so exchange participants, which are like, for example, Kaiser Permanente is just a single participant. So that's a lot of folks. We developed new capabilities in the Exchange Hub in order to implement the new requirements from the FDA, which is based on and created essentially the first nationwide FHIR-based network. We work with standards bodies to fix some standards and remediate those and create some. And then we promoted this heavily to our participants. And then we also had a financial incentives program as well too. Specifically, we give organizations with certain criteria 1 year of free connectivity to the Exchange in order to incentivize them to exchange with the FDA. And finally, last slide. So lessons learned. Just want to really share some positive and negative lessons learned. You can go ahead and advance one more slide. So first of all, FHIR query is actually relatively easy, surprisingly. It takes about a half a day for a data holder using one of the EMRs that we are known to support FHIR to configure the system to respond to data. Identification of candidates is actually really difficult, especially if you use a standards-based approach. Only about 3 MRs right now, to my knowledge, are actually supporting FHIR. But the good thing is the ones that supported are the ones that are fairly, have a fairly good footprint. But we definitely need more EMRs to support FHIR. The standards are maturing. HL7 UDAP is a great standard, for example, in terms of FHIR security for this project. And then finally, the FDA did want to use leading edge technologies for this project. And so this is, again, a national network based on FHIR. However, we do have a fallback to using SOAP and consolidated CDA as well, too. So with that, I just want to thank and recognize Dr. Hussein Esselden and Dr. Anderson from the FDA and Jay Nakashima for their leadership in this project. And the following slide actually has a few references if you'd like to get more information. So with that, let me turn it back and thank you very much.
Thank you, Eric. I know that you all have been putting questions in the Q&A. There's one in there for Eric that we'll be able to ask after we get through with the presentations. And I encourage you to start putting your questions in there and making sure that you also let me know who you want to answer them if that's relevant. So next up is Lance. Thank you, Lance, for joining us today.
Thank you. I'm Lance Jones, a data scientist and the technical project manager of the BEST Innovative Methods project for the FDA. BEST stands for the Biologics Effectiveness and Safety Initiative, and IBM has been a part of this project now for several years. Next slide, please. All right, just as an overview, the driving mission behind the BEST project is post-market biologic product safety and effectiveness. The initial driving goal for the BEST project was to develop and validate innovative methods for computational phenotypes, and to also develop a beta version of a system that's able to either automate or semi-automate the detection, validation, and report of potential adverse events post-biologics exposure. The initial work started with a beta system and quickly proceeded into the current pilot that we're going to present today. So the pilot is currently underway, and the objective there is to connect the platform that IBM has built and operates for the FDA to the eHealth exchange that Eric just discussed, all toward the purpose of a proof of concept for the potential of a FHIR-based system with national connectivity, being able to either automate or semi-automate detection, validation, and reporting of potential adverse events post-exposure to biologics. Next slide. Go ahead and click through. There you go. Thank you. So this shows the roadmap for the BEST project that has been going on now for several years. The initial foundational work started where IBM engaged with CBER. We found foundational partners that stood up sandboxes and allowed IBM to develop with agile methodology a rapid pipeline that could detect, validate, and report adverse events. As part of that initial work, more than 20 phenotypes were developed, more than 100 ICSR cases were generated and reported as part of that end-to-end beta pipeline. Quickly, one of the challenges identified was a system able to do that detection and validation, specifically if it includes more advanced machine learning techniques, requires infrastructure, data connections, and data transformations that would have a one-to-one scaling for any system you would want to deploy that on. Taking an entire server stack and deploying that on-premise or in a cloud owned by a particular healthcare system would be a challenge to any of those healthcare systems and would have a financial and time commitment. So the IBM team worked with CBER to identify potential ways to scale this solution, particularly how to leverage ongoing work in data standards, specifically data standards for interoperability, and those that we would predict would be available or that would be at a national scale. In particular, the Office of the National Coordinator's final ruling on FHIR made that a particularly potentially beneficial standard that would have national coverage, potentially would mandate an endpoint across healthcare providers for access to data. But we did know that that was not necessarily, at the time in the early parts of this project, able to have all of the data elements that we would want or desire for biologic, post-biologic adverse event validations. So two efforts were underway. We began working to develop a proof of concept for a national exchange connection built on FHIR. And we also began work with the data standards community, trying to identify gaps in standards where they related to biologics and adverse events, and to either develop or to advocate to push the standards toward public health use cases to be able to have the data that would be needed to use for regulatory grade analysis. So as you can see in the fiscal year 2021, we operationalized the BEST pilot. We also then prototyped a network connection based on synthetic data with eHealth Exchange. Currently, work is on operationalizing that Exchange platform in a pilot with live connections to data partners across the country. And we do have early adopters who are part of this pilot working with IBM, eHealth Exchange, and CBER, Office of Biologics and Pharmacovigilance as part of this effort. If you could go to the next slide. So in the early development stage, we initially identified gaps in FHIR standards by working with partners in extracting FHIR-ready data in a process of going back and forth from EHR level data to standards of FHIR DSTU2 and R4. Those are versions of the FHIR standard, which is continuously being updated and enhanced and enriched for purposes across the community. The data quality framework that we used was based on that from the Odyssey community, focusing on conformist, plausibility, and completeness. And if anybody has more questions on data quality, please feel free to reach out to me. Contact info is on the initial slide. Next slide, please. So the initial solution is a microservice infrastructure that we deployed on, that can be deployed on multiple locations. Originally, it was deployed on-prem, then on private cloud. Now it's on a hybrid cloud. The components have several layers at the beginning for data quality. Ultimately, the goal was to have FHIR as the data standard and the data format that would flow through the system. So initially, work on data quality happened on the FHIR data. Then we have a chart review tool and a detection tool. The detection tool implements phenotypes that were developed as part of this project, and I'll have another slide on those. A chart review application allows a clinician to review those data, and then a reporting interface that semi-automates the generation of an ICSR that can then be transmitted through available standards, or I should say a case report, not necessarily an ICSR. Next slide. So the phenotypes that have been completed as part of this project, we have two large groupings from more simple to more enhanced phenotypes. Simple phenotypes we sometimes refer to as either scalable phenotypes or claims comparable phenotypes. So this is where we tried to use queries or clinical query language to take what would be a claims version of structured data querying to have either biologic exposure or adverse event phenotypes. These are based on standard case definitions, such as the Brighton collaboration in relation to vaccines, as well as subject matter experts as part of the process. Over the years, then, the enhanced phenotypes were examples where we use machine learning and natural language processing to evaluate the feasibility or the utility of unstructured data to enhance detection. And there are a couple paper references at the end of the talk that you can look for more of these details. All right, next slide. So for the pilot, the best platform, it is shown on the right, the blue sections. The pilot is the IBM BEST platform that's been deployed for FDA, connecting to eHealth Exchange, shown in the middle in the orange. And then we have been recruiting provider networks that are connected to eHealth Exchange that do have R4 FHIR endpoints and are willing to participate in this project. We are still recruiting. We do have early adopters who have already connected, and we already have had success with the flow of data from partners through to the BEST system. There are two use cases that Eric mentioned that I want to go into a little bit more detail here. So the first use case, next slide, is requesting clinical charts for reviews of reported cases. This does not involve the detection step, but this is a use case that is closer to what is available in vendor EHR systems and the endpoints that they have available. So this is a use case where a known case, such as a submitted case through an official system, or a known case that the FDA wants to review, instead of having to call or otherwise reach out individually to a health system, they are able to enter a query for a particular case in the BEST platform that's then federated in the middle, in the orange section, to eHealth Exchange, where eHealth Exchange fans that out to participant sites that may have records relevant to that case. And that's where the potential power of this solution really has the potential to enrich available data. Because in the case of a vaccine, you may not have just a vaccination at a site such as CVS or another, Walgreens, all of these various locations that are administering vaccinations, but also at a hospital, emergency room, or clinic. They're able to then retrieve those data and submit them back. All right, next slide. The final use case then is the one that is we are currently working on, but this is less supported by current standards and implemented technology. And this is where queries are initiated at a particular healthcare site, pushed through the exchange to the BEST platform, where cases can then be further evaluated. And before I close, on the last slide, here are references. If anybody is interested, we are still recruiting participants in both the push and pull use case, and we'd be happy to have anybody reach out. Thank you.
Lance, thank you all so much. Oh, there we are. We are now at our Q&A time, and I know I have a number of questions, but before I do that, there have been some great questions and answers already. I want to just recap them because some people don't know where the answered bar is, but just really quickly to Eric, how can researchers access the eHealth Exchange data? There's a written answer there, but just quickly, if folks don't know how to find answered.
Sure. So Health Exchange is, I'm not an attorney, I'm a technologist, and so I'll answer from that perspective that, I think that what we would do is, and I chatted the contact information in the answer, just have you reach out to Health Exchange through the either administrator, healthexchange.org website or email address, or to myself directly, and we'll route you the right person to understand your use case, what kind of authorities you may have as far as acquiring the data under regulations or HIPAA or things like that. And I'm happy to work with you. And I definitely would, think that there could be some use cases, especially using the new FHIR capabilities of the exchange.
Great. Thanks, Eric. My first question actually goes to Margaret. If Margaret, you're with us, great. Thank you so much for all of the information on how we can get to know what's happening with Sentinel. And you talked about a master plan. What have you found to be most effective in reaching people is the first part. And the second is, what can we expect moving forward?
Excellent. Can you hear me, Tanisha?
Yeah, I can.
All right. Fantastic. So I think one of the things that has been interesting that we've been finding is, there's sort of this general awareness of Sentinel, but when we've dug in with the webinars and the newsletter and, refreshing the website, people are interested in the granularity in terms of the stakeholder community. They want to know more, and they want to know what are the essentially use cases. So that's one kind of aha observation. And then I think in terms of what to look forward to, it's more of that kind of digging deep into those different stakeholder communities and thinking about potential opportunities for partnerships and things. So I think there's a lot of fertile ground still to be tilled on that.
It's great, Margaret, and I know it'll probably spur more questions, but in the spirit of use cases, Grace, it was great to hear about the work you're doing at the CDC focused in Lyme disease. For us, do you have any other public health use cases based on what you learned in this one that you feel like it can be applicable to other disease areas or situations?
Yeah, I think we're really just scratching the surface about the potential applications here. I think probably the leading limitation at this point is lack of awareness within the agency, and I would expect the same is true at other federal agencies as well. You know, I mentioned Market Scan. We have a lot of experience using Market Scan in my team, and I think there's just more awareness about it being kind of easily available through the licensing that's already exists. But I think there's a lot of, which I highlighted, I think potential benefits of FDA Sentinel in reaching those other kind of population gaps that Market Scan has, and provides such a richer data set to look at broader populations of interest. And I think that's only going to expand as time goes on. So as I mentioned, I think there are a number of different things that we can do in our team in the Center of Emerging Infectious Diseases, but I think that this could also be something that's applied more broadly. I know other things that have been looked at using FDA Sentinel include tuberculosis, various prescriptions for both latent and active tuberculosis. There was also an investigation looking at the applicability of FDA Sentinel, looking at different treatment regimens for diabetes and looking at broader kind of surveillance for diabetes. So again, I think it really spans the gamut of all of the conditions and diseases that CDC surveys. And I think as time goes on and awareness goes up about what Sentinel is, I think we'll be seeing more and more of those examples come to fruition.
Great. Thank you so much, Grace. Eric, you talked about the fact that although the eHealth Exchange was small, but you're mighty as it relates to the investment that you've made to make sure the quality of the data is in a place where it makes the data more ready for analysis. Can you elaborate a little bit more to our audience as to what that means and what that leads to in terms of usability?
I'll be happy to. So one of the things we've discovered probably about 3 years into our history, back about 2000, maybe I don't know, 13 or so, 2014, was that the data quality just wasn't where we expected it. You know, organizations were using HL7 and IHE standards for data exchange. However, there was no enforcement of those standards. And so what we saw is, for example, test data didn't represent production data. And so what we did is we actually work with a standards body that I'm a part of called IHE International. And we actually collaborated with Switzerland, with South America, with Dubai, many other countries worldwide, all kind of pooling our financial resources to focus on improving one open source quality assurance tool called Gazelle. And that's been invested in for 15, 20 years now. Anybody in the call that's been through an IHE Connectathon probably has used that open source product. Anyway, so we invested in Gazelle, and we went back to the HL7 and other data standards, and actually we line by line, field by field, looked at where the structure should dictate the data be placed. We also looked at what values and code systems were required. And then we looked at real data and production PHI containing data to see if it was conformant with, is the data structured correctly and are the values permissible? And we found basically almost everybody failed. The first few months we implemented this mandatory program. We did give organizations several years to remediate their systems, and it is contractually enforceable. We actually have the right to be accurate, the eHealth Exchange community has the right to remove people from the eHealth Exchange community if their data quality is not sufficient. The other layer, and so we have a tool called IHE Gazelle that actually does this data quality assessment against PHI containing data or synthetic data, test data. But the other dimension too is I'm really a huge believer that everything starts in policy and use cases, even though I'm a technologist. And so the use cases actually drove the data quality tool. So in this case, we actually have a number of industry approved use cases such as transition of care, discharge summary, public health surveillance, public health reporting, things like that. And those use cases have different constraints on what data are needed for the use case to be successful. And so those use cases drove this overall process as well too.
That's great. I want to go back to Margaret, if you don't mind, we talk a lot about Sentinel being a national resource, and, based on where you sit in terms of hearing back from stakeholders, what do you think is going to be needed for us to really get there? Is it more awareness building? Is it innovations to make the data easier to access?
Yeah, I think it's all of the above. And I think that the Sentinel is definitely making great strides towards that. I do think, what we witnessed during the COVID-19 pandemic in terms of the agencies in particular being able to quickly thread together to create, pretty astounding outcomes, I think. I think that we have, sort of macro level use cases where, a national resource such as the Sentinel Initiative, will certainly be useful going forward, and I know was useful. And so, yes, I think more of those opportunities, more sort of gathering and exposing these use cases, to broader communities. But absolutely, I think it is a resource. Tanisha, you and I know from our days in health policy, it has been talked about that really from day one. And so, I know for me, and I'm sure everybody who's participating, it's sort of an honor to be affiliated with it.
Yeah, it is. And I don't know if anybody else wants to answer that question as well. And, we talk broadly about stakeholders, but, there are different stakeholders for different uses. Grace, I was so intrigued that the study that you did really led to a different approach for an educational effort. That's wonderful. And anybody else want to reflect on that question of becoming that national resource, and what will it take?
Well, just to add on briefly. So, one of the things that's always been kind of a little frustrating for me as a software architect and a data standards person is, we have all these use cases nationally and priorities such as public health, n is greater than 1. We have n equals 1 use cases. We have administrative rules under HIPAA. All those are just starving for data. Payers are starving for data, and the exchange has that in structured format. So, and we're a nonprofit charity. We're not getting rich off of doing this. We're just doing it for the public good. So love to see more engagement. And, like we work with the FDA, we understood their use case. We understood their data requirements for the minimal data set. And then we built, a program backing into that use case. So love to do that for others as well. Great.
Lance, do you want to get in here as well?
One thing I would point out is we sometimes talk about data standards, especially when we have the research, the research lab coat on, and think in terms of whether it's suitable or not suitable for purposes. But I think there's something to be said about assessing where it is now, looking at where the standards need to go, and then actively engaging in the standards community to move the data where it needs to be. And for public health, I think that's something that we've had some initial success with, and that we're also trying to continue to do. The data are not always there if a standard is developed for a different format, such as FHIR, but through engaging with HL7, for example, biologically derived product was a new resource that was put together by the IBM and FDA team for data that was not available, but easily could be available, and help public health use cases and tracking of a potential, say, for instance, a transfusion event. ISBT numbers are not available in FHIR unless you support that. So I would encourage active engagement in the standards community as well.
That's great, Lance. And Grace?
Yeah, I think a couple of thoughts there. I think one is, of course, awareness. We've talked about that already. I think two is just making it accessible and easy. Making it a clear way to access the data, something that is easy to understand, that's accessible, and that those pathways are established. I think there's also broader, the broader context of data modernization, the DMI, Data Modernization Initiative at CDC. I think it's a clear opportunity for making this a priority. I think FDA Sentinel, an obvious partner are the other federal agencies. We're not perhaps starved for data. I think there's other data streams that are available as well, but making this one accessible and an easy one to reach for quickly, and establishing those relationships and those partnerships, I think would go a really long way.
It's great. I know Eric weighed in on this, but I want to ask the rest of the panel. This has been a great panel, particularly focused on COVID-19 and medications. Can we expect future Sentinel programs on unique issues and methods, such as the National ICD Registry, or reporting issues for devices as well? I don't know if anybody on the panel wants to take that. Eric, you can weigh in on your point of view.
My hope is that the work being done right now by the CBER is the thin edge of multiple similar use cases for the FDA and others. It's a pattern. Once we have this data flowing from data sources like hospitals to the FDA based on configurable criteria, which is what we're working on now, that criteria can be modified for a variety of use cases, such as adverse events due to blood products or medical devices or other regulated products as well. And then it can be also the same exact pattern can be reused by the FDA and others to follow up on individually identifiable cases to determine that patient's longitudinal history and potentially even track that over time, as granted by authorities, to give really an unprecedented insight into any kind of correlating factors.
Great, thanks, Eric. Anyone else?
Tanisha,
Yeah,
I don't have a comment specifically on that. So if we want to go to Lance, but I wanted to bring up data standards and data science.
No, please go ahead, Margaret.
I just wanted to make kind of that macro level observation, stating the obvious, that in the time that I've been working in health policy with patient organizations, as I know you have as well, Tanisha, we've talked about data, we've talked about data standards, we've talked about, fluid data, the answers are all there. I finally feel like we're there. And I finally feel like the use cases are there. And I finally feel like, the momentum is there. So Matt Herper recently called it the century of biology. I think it's a century of data. And I think, the keys are there. And so back to your point about the future, with Sentinel, I just think this is going to be an area, particularly for advocates, to really be focused as we're advocating for these agencies to have resources to be able to do this work. And I think also putting a plug in there for STEM education and data science education. And I just think that new group of health professionals hopefully will be, more sensitized to the possibilities that exist in resources like Sentinel. So there's my stump speech for data.
I always appreciate Margaret has this magic of so what she calls stating the obvious, but it actually cuts through a lot of the technical details we're talking about to bring it up to a level that we can all relate to. So Margaret, thank you for that. And on that note, I'm going to dive right back into some details too. We got a really great question around the type of phenotypes that the BEST system will be focused on moving forward. Lance, do you want to take that question?
Sure. So over the years, the main focus of our phenotyping was on transfusion outcomes and transfusion events, potential transfusion adverse event outcomes, and then switch to vaccines for somewhat obvious reasons. And so we've been looking at COVID-19 vaccination exposure, other vaccine exposures, and then vaccine adverse events. The particular adverse events we've been starting to review are in line with the other BEST presentations that you've heard as part of this. So the larger studies there out of the BEST data tools research are the ones that we are now taking from the claims algorithms into the FHIR-based algorithms.
Okay. And then maybe I didn't hear this right, but as I understand it, Sentinel and BEST use a common data model, but the eHealth Exchange does not. Is that right, Eric?
Yeah, the eHealth Exchange is data agnostic to a large extent. We will allow any types of applicable data to be exchanged, including things like TIFF files for, say, EKG traces, which the Department of Veterans Health Affairs used to use fairly commonly. But where standards do exist, we require that they be used. And then where certain key standards exist, such as CDA or FHIR, we also have quality assurance dimensions we also check for.
Great. And I have a question for Grace. Grace, we heard a lot yesterday about the importance and the value of linking administrative data with public health data. And we've been hearing about the success of BEST and building out these linkages as well. What do you think needs to continue to be done to think about these linkages with public health, all in the rubric of the future of, how CDC is thinking about data to begin with?
Yeah, that's a really big question, and one that we've been really agonizing about at CDC for decades. Really, I think it's really, COVID kind of brought all these conversations to a head. And I think there is momentum now that has not been there before, and more money and attention to the issue. But I think it is it has been really a constant struggle about how to bring public health surveillance into the modern age of data, and it's so far behind where it needs to be. I think these systems like FDA Sentinel are really important to be to be at the table while we're kind of overhauling that system, because it's there's a lot of moving parts right now, and a lot of just a huge amount of momentum, and new centers really being stood up to address this issue. And I think now, as I mentioned, it's a good time to really springboard from COVID and think about new opportunities for alignment of these big data systems.
That's great. I have a question from Margaret. I don't spend as much time as I would like in the world of data and what exists and how it's evolved. I'm very encouraged by your comment, Margaret, that we've been talking about it for a decade. It's actually here. When you're out there engaging with stakeholders, do they understand sort of what's BEST, what's the eHealth Exchange, what's Sentinel, how does this work together? What can we do to help clarify that for potential users moving forward?
Yeah, and you might want to ask Eric, because I saw him resonating with my comment. I definitely think that the capacity is there. I think in the not-for-profit sector, the resources aren't not always there, but the yearning and capacity, and if we remember, a lot of those groups were initial, kind of jump starters in terms of pulling patient data, gathering it, trying to figure out where it should live. So I do think the awareness, interest, and all of that is there, and I certainly am seeing it in spades across all of the federal health sector. I have a good colleague who's a data scientist, and I think data scientists were, having to sort of be out there in the wilderness a little bit for a while, and maybe not mad scientists, poorly understood. And I always say to him, it's your time. It's happening. It's here, and it's phenomenally exciting, right? Because we have been hearing about it. I mean, our former boss, Mike Milken, used to talk about, I'll put my electronic health record out for anyone to study. And it was like, that's not the point. A single electronic health record. We want them aggregated. We want them searchable, all of it. But I mean, people have been thinking about this, and we certainly know it exists in all of the rest of our lives. So I would love to hear others opine on that.
Yeah, please. And to the extent that we've been talking about data, but just as important, Margaret's saying, is the talent that it takes, right? I was always, having just been in the government, I tried to pull together all the risk communicators that live in all these different agencies. They'd never talked to each other before. So do we have the ability, do we have already a data scientist federal sort of conference for all of our data scientists? But so please opine on not just the data, but the talent needs that we have.
Well, I definitely think there's a gap, but I think we've got people that recognize that a number of years ago and starting to see the benefits. I had the opportunity to provide a lecture last week to a group of healthcare informatics professionals at the university here in Texas, and one of my comments was, please get involved as you go into your jobs in the future. Please let them know standards are important, and they need real world informaticists and clinicians' perspectives to make sure those standards actually work as appropriate. To Margaret's point about contributing data, actually one of the projects I became aware of recently is called All of Us by the National Institutes of Health, where they're seeking, I see a few thumbs up, basically 1 million people voluntarily contributing their data for research purposes, and I applaud efforts like that. Can't get enough of that.
Great. Anyone else want to reflect on the conversation?
I think from my perspective, the community does seem to be coming out of the pandemic lack of conferences and visiting and traveling. This year has been a bit more, but it doesn't feel like we're quite back to the level of community pre-pandemic. So it would be, I would encourage everyone to get involved again.
I'll say when we, when myself and one other person started the Health Exchange back in 2012, my vision was where we are today. Basically, I mean, everything we've done now is just to connect the pipes and make sure the right stuff is flowing through them. And now we've enabled us to actually do all these amazing things with these data that are actually now available to us. So let's leverage it.
That's great. Grace,
do you
any
agree,
reflection?
Eric, that it used to be a little bit like the wilderness, or you felt the wilderness?
Yeah, a very hostile wilderness, maybe on an alien planet.
We're all friends here.
No more your time has come. Your time has come.
But we've invested as a country billions of dollars, right, on getting all these records computerized, and now to get them to high quality data, we've got to use that right.
Do. Grace, any reflections? Final reflections.
I think just one of the perennial challenges within the federal government is the propensity to silo. I think that by nature of the way that our funding streams come in, by the way that that we are organized in our org charts and by subject matter, I think it really limits us in terms of reaching across the other partners outside of our agency, and even sometimes within our agency, to access things like different data streams, and again, connect the pipes, because I think that that's what's missing in a lot of these conversations. We have a lot of conversations internal to CDC, but it's often more of a struggle to make sure that those same pipes are connecting across agencies.
We actually, our nonprofit application with the IRS, our mission is to ease the burden of federal agency, private sector interoperability. So one of the things we've actually done is become, kind of embedded experts, the Department of Defense, Veterans Health Affairs, other agencies, trying to help, say, okay, here's how your agency can leverage, benefit, and share with the private sector. So it's certainly a challenge, but there are solutions. The DoD today shares data bidirectionally with the private sector for every active duty military personnel, for example. If they can do it, all of us can do it.
Well, I definitely would say it is events just like this that help us bring community together in different ways. And I want to thank each of you all for giving people very tangible examples and case studies for how Sentinel is a national resource. Margaret, to you and the Deloitte team for all the outreach and the community building that you're doing. I am wanting to know whether Mark has joined us, or if I can fit in one last question. I think I get one last question. Okay. If you were to wave a magic wand, what kind of partnership would you want, either between federal agencies or the private sector, moving forward that would enhance sort of the impact and the value of Sentinel? Ponder, ponder, ponder. Who wants to go first? Lance.
That's a magic question. I think the siloing would be the main thing that I would want to. I would want to wave a magic wand to get the key, all of the key stakeholders together, to get one approach to it. That would be, I think, helpful, because there are many parallel approaches all aiming to the same direction that can benefit from more communication. So I think that would be my.
That's great. Okay, I think we have Mark with us. So you may have been the last word, but I will just remark that thank you all so much for this great panel. And now I'm going to hand things over to Mark.
Thanks, Tanisha. Thanks, team.
Thank you all so much. Great panel discussion, and it's good to be back with you to wrap up what's been a very productive and very engaging couple of days. I want to give us thanks not only to the panelists on this last session, but all of our panelists throughout the last couple of days. Obviously, there's a tremendous amount going on with the Sentinel Initiative, and we really appreciate all of you joining us to share these ideas, discuss them, and think more about where to go from here. Building on the great discussion that we had yesterday heading in today, we heard about some of the key research studies, the key areas of innovation that the Sentinel Initiative is undertaking to improve and impact regulatory decision-making at the agency. We had another engaging discussion that covered a range of key issues, including technological advancements and methods development to improve the set of tools and analytic capacities for use in the Sentinel Initiative. We heard a lot about data as well, the advantages of linking data and new opportunities to do so. We spent time exploring the challenges and opportunities around electronic medical records, combined with claims in particular to improve longitudinality and utility, fit for purposeness of data, so that we could improve the insights that can be derived from Sentinel analysis. We also talked about some key priority issues around improving the efficiency of accessing data, and particularly unstructured data in electronic health records. This included some use of natural language processing, machine learning methods that could help us get even better access to meaningful data from text. With these data improvements and with the access to more contextualized data, you can see how the community is moving towards the development of richer computable phenotypes and other innovative ways to automate and scale out the identification of important drug safety outcomes for the purposes of the Sentinel fulfilling its mission. And also, I'd say, being at the cutting edge of how and contributing more broadly to research capabilities related to real world evidence and the understanding the key issues of the underlying data that are so critical for determining how useful that evidence can be. In this last session, we talked about a few important developments in how Sentinel is expanding its partnerships to build out new capabilities to support broader applications, including public health surveillance, something really important in the COVID pandemic, as well as leveraging additional types of data sources, e-health exchanges from the state exchanges for health insurance, as well as we talked about yesterday too, the big expansion to use of Medicaid data. And again, a lot of benefits and synergies with efforts to expand other types of real world evidence development using a broader range of data sets, just as Sentinel is helping to lead the way in doing. So lots of progress towards the vision of Sentinel as a national resource and strategic tool to scale evidence generation as part of a learning healthcare system, but still a lot of work left to go. And so that means that while we're concluding the workshop today, we're certainly not concluding the efforts to continue to build out and increase the impact of the Sentinel Initiative. And so I'd like to thank everyone again for their time over the last couple of days, as well as thank them looking forward as this collaborative public-private enterprise continues. So first, a thanks to all of our speakers and panelists who shared their current work and future plans with us, all of their insights. We covered a lot of impressive developments and milestones over the past year, and a lot of very interesting plans for what can happen as the Sentinel Initiative continues to plow the ground going forward. I also want to thank all of the colleagues on the FDA planning team that helped put this together, including Bob Ball, Stephen Anderson, Rich Forshee, Jamila Nwadu, and many, many more. And of course, our team here at Duke-Margolis, a great set of contributors to the efforts around advancing real-world evidence in general and the use of real-world evidence for improving safety and effectiveness of medical products in particular. Our moderators, Rachel Hendrick Stirrup and Tanisha Carino, our project staff, including Mariam Nafi, Luke DeRocher, Matt D'Ambrosio, Thomas Rhodes, Aaron Sewell, and Adam Atten. Special thanks to Adam. And finally, thanks to all of you who joined us this time. Thanks for coming, and thanks for your continued interest and contributions to the goals of the Sentinel Initiative. I hope you have a great rest of the day.